And we're back. So how did you guys like that lunch? So at this point in time, we just wanted to say thank you to Lilly Oncology, which is our sponsor for the evening, for the conference. And they are the ones that are responsible for the delicious food that you guys just enjoyed. So thank you very much to Lilly. The next person that I would like to introduce is Dr. Natalie Coburn. She is a surgical oncologist specializing, and please bear with me here, gastric, hepatopancreatico-biliary cancers. So that sounds like a mouthful, and that is a mouthful for sure. For those of us that don't know what that means, it basically means that she specializes in GI cancer, so including the stomach, liver, pancreas, and gallbladder. So she actually holds the Sheriff and Mary Lou Hanna Chair in Surgical Oncological Research at Sunnybrook Hospital. She's an associate professor in the Department of Surgery and Health Policy Evaluation and Management at U of T. And, you know, she's just been a great champion for us. We met over the last couple of months, and she just can't stop promoting us, and we would like to return the favor and promote Dr. Coburn as one of our champions at MyGutFeeling.
Thank you. I'd like to thank Katy and Teresa for organizing all this. This is fantastic, and I think this is really what the community needs and what our patients need. I'd also like to thank Lilly because they have done a phenomenal job, as Howard mentioned. They bring a bunch of physicians together in multiple different ways to support gastric cancer, and as a company, they've also done a tremendous amount for gastric cancer. So I am one of the surgeons up at Sunnybrook, and I treat gastric, and I also treat liver and pancreas cancers, and I'll talk about a little bit of my research today. I also have nothing to disclose. I do work also with Cancer Care Ontario, and so I'll talk a little bit about how they're involved in some of the things we're working on from the research projects. So the question is why, and how do you get to be a gastric cancer researcher like Christine or like Howard when you see two of these in your training? And what happened when I was a resident, when I was training, you look in the textbooks and you look at how things are described in the textbooks, and you look at how things are being taken care of in your clinic or in the operating room where people are teaching you how to operate. And what I saw was that there was a difference between what I saw in the textbooks and what I saw in reality. And I began to ask why and how can we do better. So when I established my practice, I started at Sunnybrook. I actually came from the US. I came up here as a fellow, and I stayed at Sunnybrook. And so I have a 50-50 career, so I do 50% clinical. And so on Mondays, I'm in clinic, as people may know. On Tuesdays, I'm in the OR, and on Wednesdays, sometimes I'm taking care of patients on the ward. And the other half of my time is doing research and writing reports and working with Cancer Care Ontario and teaching residents and surgical oncology fellows. And this works out really well because we have a situation where what you're doing in clinic and what you're seeing with the patients, just like what Dr. Lim is seeing, gets translated to your research, gets translated to your productivity in your teaching, and hopefully this all drives in a cycle of improving care for patients. And so what do I study? Well, they study genes, and Christine studies chemotherapy. I study Ontario. This is a great thing to study as a health researcher because everyone has the same access to care, theoretically, and everyone has the same coverage. So you can see how it's easier to study health outcomes in Ontario or in Canada than it might be in the US. So I study what's going on here. And the way I study that is through a group called ISIS, which is an unfortunate name these days, but it's the Institute for Clinical Evaluative Sciences. They had this name a long time ago, and they're thinking about rebranding. But basically, everything that happens in the province goes there. And it's a building that's located at Sunnybrook. So if you see a physician and a physician submits a bill, that information goes to Sunnybrook. If you go to the emergency department, that information goes to Sunnybrook. If you fill out that symptom form in the cancer clinic, and we'll talk a lot about this in a second, that information also now goes to Sunnybrook. If you get chemotherapy, some information about pathology, and if you have surgery or radiation, we can figure this out through a ginormous database and a lot of programming work. But this is what I study. And the reason that we study this is because if you cannot measure it, you cannot improve it. And I thought about a little bit about what I'm presenting here today, and some of this data is not good. Some of this is ugly, and some of this is not perfect results. And I think we stand before you saying, we're not doing perfect, but we're trying. So take that under advisement as I go through this. This is also some older data, and I'd say things are improving, and I'll talk about some of the ways that we've improved upon this. So as we go through it, maybe think about how old the data is and what we knew back at that point in time, and maybe that's why the results were as they are. So the first question that I want to answer here today, and one of the things that we've been very excited to work with, is the symptom data from across the province. And so I want to talk about the burden of symptoms in gastric cancer patients. And what we do is we take that data, and probably most people in this room know what this sheet looks like. This was instituted by Cancer Care Ontario. And they started in 2007 looking at outcomes. And they started with lung cancer patients, but then they quickly realized that they could apply this to breast cancer, colon cancer, gastric cancer. And so when you go into your cancer clinic visit, you fill this out, and you say, do you have pain or tiredness or nausea, lack of appetite, depression, well-being, any other problems? And they began gathering all of this. And they gathered all of this, and they've been pulling all this data in, and then they said, wow, this is a lot of data, but we haven't really done anything with it. And so we brought that up to ISIS, and we started looking at symptoms. And the first thing I, of course, said, we need to look at gastric cancer symptoms because surely these patients are quite symptomatic. And so we looked at over 3,000 patients, and we looked from 2007 to 2015. And the first set of data I'm going to talk about is the time around diagnosis. So we use the date that you get registered into the Ontario Cancer Registry and look forward for 6 months. Most of the patients have an ESAS score, which means that they are seen at a cancer clinic or one of the hospitals that's doing these scores. And you score everything from 0 to 10, and we consider greater than 4 a moderate symptom, and that's what the literature considers. Greater than 7 is a severe symptom. And so what I can say is I don't think we do a good job. So this is symptoms from month 1 to month 6. So this is around the time of diagnosis. And this is moving up to 6 months after you're diagnosed. And I think what everybody can see here is that we really don't improve upon things as you're going through the system. And maybe we improve upon some things, but then we add surgery and so it gets worse, or we add some chemotherapy so it gets worse. But basically, we don't really do a good job of making people feel better as they go through the system. So this is an average score of 4. So it's not terrible scores, but certainly we're not making things better. And so I'll talk about what each of these scores is. Who can tell me what this top score is? What's the worst symptom that people report with gastric cancer?
Nausea.
Okay, any pain? Any other guesses? Tiredness. So I'll talk about Mike Evans, because he knew this before we showed this. He was a physician actually here at St. Mike's and has gone to go work in the US. He has this phenomenal collection of YouTube videos, and he talks about this one. Whoops. You have the volume?
A quiz for you. I want you to guess what the most common medical issue is for people on the cancer journey. Maybe pain, or depression, anxiety, lost appetite. Turns out the biggest complaint in people with cancer is fatigue, tiredness, exhaustion.
So he talks about that, and he talks about what to do with it. And counterintuitively, what you need to do about it is actually get out and exercise. And he goes through why you need to do this and how it improves, and how it improves your tiredness. And he has a whole set of videos, if you just look on YouTube. They're really quite instructional. And so the top one's tiredness, and it doesn't get better. So it stays about the same, and it stays highest. Then we come into appetite and well-being, which is not surprising with gastric cancer. Anxiety. Anxiety is the only one that goes down. We find quite consistently across all the cancers, anxiety is really quite high in the first month, and then as we come up with a plan, as we come up with a treatment plan, anxiety goes down. then pain and shortness of breath. But overall, I think we could do better improving upon symptoms. The next thing we looked at was symptoms prior to death. So we looked at the same years, 2007 to 15, and we looked at patients who passed away. So when within our database we can tell that the patients have passed away, we looked at the 6 months leading up to death. And I think that this is a really crucial time, and we're going to discuss support of patients and families in a few, with some of the next speakers, but this is something we all need to look at as well. So a third of the patients were diagnosed less than 6 months prior to death, and this obviously gives us, as healthcare providers, less time to put support systems into place and for families to put supports into place, but it's really quite important. And so again, we use this score of 4 as a marker of moderate to severe symptoms. And this we looked at slightly differently. So this is the percent of people reporting 4 or higher. So you could report a 10 or a 4, and you get into this proportion greater than 4. And this is the time around death right here, and this is when you present leading up to death. And the proportion of scores greater than 4 is quite high. It's about 60% here. And as time goes on, it gets worse. And as we get in this month time period right before death, unfortunately, we have 70, 80, 90% of people presenting with severe or moderate symptoms. So again, this is a baseline, and this is where we are, and we're working to improve upon it, but this is the first look at the data. Those are the same symptoms: overall well-being, tiredness, and lack of appetite that are the most troubling. What we can also tell is that when you present closer to the time of death, the symptoms are really quite severe. So here we have 70% of people presenting with moderate or severe symptoms if you have a very short diagnosis period. And I think this represents our struggle to get adequate support into place. And this is something that Cancer Care Ontario is looking at, and we're looking at this with their patient advisory committee. And if you want to volunteer for a patient and family advisory committee, they have an excellent group. Obviously, some of the more common cancers are more commonly represented, and it would be fantastic to have somebody from gastric cancer there on this advisory committee, because simply right now there's not anyone. So the next question is, how are we doing in terms of other things? How are we doing in terms of surgical outcomes, survival outcomes, and how are we doing with providing equal care across the province? And again, I'm not sure that this is the best data to be proud of, but this is where we are, and this is our baseline. So what we did first was looked from 2005 to 2008. We looked at every patient with gastric cancer across the province. We sent someone to every hospital in the province, and they pulled out the charts, and they went through the charts. And the reason is because a lot of the things that we need to know, like the radiology reports and the pathology reports, are simply not brought into to the larger databases. So Ivanka went out to every single hospital. It took 18 months. And what we looked at, mainly, because I'm a surgeon, we looked at a lot at the resections and what happened with the resections. About 1,000 patients went to resection. About 700 of these were curative intent resections. Some of the resections were performed for palliation, bleeding, obstruction. Most of the surgery was performed open. This was about 10 years ago, so this is very reasonable for that time frame. 6% were performed laparoscopic. We looked at survival for these patients and how they did, and we compare, I compare ourselves to the East. I don't compare ourselves to the US because I don't think that's a good marker of the best quality of care for gastric cancer. If you look at US numbers, they look really quite similar to Ontario numbers, as we were discussing this morning. If you look at compared to Korea, the survival's worse. There's a number of reasons for that, but this is what I would consider a benchmark that we want to strive to. When we look at the surgery, we know that we're not always doing the best quality surgery. This is 10 years ago. The percentage of patients who had an adequate number of lymph nodes assessed was 40%. I can tell you Cancer Care Ontario looked into this and published, put out data in May, and it was up to 60%, but it's really not as high as we want it to be. The percent of margins that were positive, or there was cancer at the margin after surgery, was 8% towards the esophagus and 8% towards the duodenum. This is also not where we want to be, but we're making steps to improve upon this. And then question number 3 is there variation in treatment across the province? And how might that affect patients? And what care is provided, and is it the same in London as it is in Toronto? And I think this becomes a bigger question if you ask, is it the same here versus Halifax versus BC? And the answer is, of course, there's variation. So we look according to local health integration networks, which is the area of the province that you're divided into. So they're mostly centered around larger cities, 11 centered around Ottawa, Kingston, Durham Regional, London. Toronto's this little bitty one right here, but that's much of the population stuck into number 7, and then Northeast and Northwest. And so if we look at the LHIN that provides the highest percentage of whatever thing we're looking at versus the lowest, we can see that there's significant variation. So there's variation in the number of times you go to the emergency department, which probably is reflective of how quickly you can get in to see your family practice doctor. There's huge variations in the number of specialist visits people get between the LHINs. These are not necessarily the same LHINs that are being represented here. There's variation in the percentage of patients who get chemotherapy for stage 4 cancer between the LHINs, radiation, and resection. So across the LHINs, there's variations that we really don't understand why they exist. Maybe patients were offered chemotherapy and they refused it. Maybe patients were not well enough to get chemotherapy here. But you would hope that those differences would be about the same between the LHINs and patients would get the same care. The number of hospital admissions is variable between the LHINs. But I think that more importantly, the number of days you spend in the hospital is also very variable between the LHINs. And then the amount of home care visits, which is probably inversely related to the number of days you're in the hospital, is variable between the LHINs. And I think we need to work to improve access to home care for all of the patients and access to palliative care so that you can stay out of the hospital and stay at home where you would rather be. At the end of the day, some of these variations probably do impact survival. This is a study that Alison Mahar did for her master's work with me, and she looked just at the stage 4 patients between the LHINs to see what the survival is, and unfortunately, it is variable. So all of that has led to kind of the other part of my life, which is working on reports and publications. And we worked with Cancer Care Ontario to create surgical guidelines for cancer care for stomach. Same thing exists for breast cancer and colon cancer, so it's not unique for this to be necessary for gastric cancer. I think the necessity in gastric cancer is larger, though, because it is such a rare disease, and it is spread out across many, many hospitals within the province. So these are things that Christine was talking about, the multidisciplinary team meeting. All the cases should be discussed there so that everyone can have input into how the patient is treated and so that the best treatments can be selected. The quality of radiology is important. The quality of surgery is important. And the quality of support for the patient is important. And I think as we have this document, Cancer Care Ontario can look at which areas of the province are excelling at this, and how they're excelling, and how does the team work in an area like the GTA to provide very good care. And we're working very hard as a team between the medical oncologist and the radiation oncologist and the major teaching hospitals to try to improve upon care. And is that same care being provided elsewhere? And that's really what we're striving to do. This all takes a huge amount of work. The symptomatology data is done by Lev Bubis, who is a surgical resident, and much of the other work is done by Alison Mahar, who just completed her PhD at Queen's. But as you can see, it takes a huge team. As I mentioned earlier, it takes a huge amount of funding to run enterprises like this. And if there's other questions that you have that you'd like us to look into, we'd be happy to assist in that. And I think Teresa's going to talk about this later on, but we're really excited to be part of all of this, and thank you for inviting me to speak today.
Thank you so much, Natalie. I just actually wanted to make a very brazen promo here. So, as you know, Natalie reached out to us in the summer, and we met, and it was instant chemistry in terms of the kind of work that we wanted to do together. And so one of the things that we're doing in collaboration with Sunnybrook Health Sciences Center in Toronto is the Stomach Cancer Awareness Day, which is on November 30th, and it's this Thursday. And in Toronto, it's in collaboration with Sunnybrook Health Sciences Center. And what we're doing in Toronto is we're lighting up, well, we're not personally lighting up, but the CN Tower, the City Hall towers, and the Toronto sign will be lighting up in periwinkle blue in honor of Stomach Cancer Awareness Day. And then beyond that, we are lighting up in 5 other cities across the country. So Vancouver, Victoria, Edmonton, Halifax, and Montreal will also be lighting up in periwinkle blue in honor of Stomach Cancer Awareness Day. So it's an initiative to raise awareness for this disease, to raise some funds for the programs that we hope to continue to provide to everybody. And we're really excited about it because it's the first time it's kind of been done across the country, and it kind of gives us that, we're going to be that national voice of awareness for stomach cancer. And it kind of really started with Natalie because she said, hey, why don't we try this? And then we just reached out to all the different cities, and so city halls will be lit up, and you can participate, and we'll have more about it on our website very quickly, because we do everything very quickly. So I just wanted to thank Natalie for that, and just for all the work that she's done. So if there's no questions for Natalie, we will have another panel discussion, and we'll take those questions afterwards. So our next speaker is Ramandeep Bagga. I met Ramandeep actually through his wife, Megha, who was a patient, and she had reached out to us through Facebook. And so I connected with Megha, and she was going through treatment at the time. And then I met Ramandeep, and I met all of their family. I will not go into the story because that's Ramandeep's story to tell, but he's one of the most incredible caregivers that we have met. And the caregivers are actually very important to us because usually it's the caregivers that approach us first, because sometimes the patients are having a really difficult time. So sometimes it's the caregivers that reach out to MyGutFeeling first. And so for us, it's a very important voice for us to have, and they're a very, very crucial part of our group and of our organization. So Ramandeep.
Good afternoon. Thank you, Teresa. I think Teresa and Katy are doing a wonderful job. They're being change agents. I've been attending a lot of sessions recently at work on change, and I think change anywhere, in any form, shape is important. And I think having gone through what I have, it's really wonderful to see that we're having the day today here where everybody is sharing what's happening. I'm actually incidentally part of the pharmaceutical industry as well. I'm in the drug industry, and I do know that a lot of good work's happening out there, and a lot of people are putting in a lot of effort to get here, to make sure that we have better stories to tell, and caregivers and patients have better days ahead and longer days ahead. So I've put a few slides together. How do we get it? Yeah, perfect. Thank you. Okay. So I thought pictures speak a lot of words, and I thought I'll put a few pictures up there. And essentially, it's about Megha. It's her journey, and basically my family, all her friends, we basically were part of her journey, and I wanted it to be in her words, how she would have liked to express it. So incidentally, the photograph that you saw was when she got her G license between her chemotherapy. She failed it 4 times, but she wanted to make sure she got a G license even though it was between the chemotherapies that she was having. So that was a good thing. I'll just try to put a timeline together, and I'm not going to go into details, but I was just talking to somebody over lunch, Kathy, I do remember the name, so I'm going to highlight that. That one of the biggest issues through our journey was that she started showing symptoms in very early 2015. Incidentally, like Jan said in the morning, we came back from LA after a vacation when she started showing the symptoms. It was not till 1st of March 2016 that she was diagnosed. She went through bouts of scopes. She went through biopsies. She was turned away from several hospitals for getting second opinions because nobody took it seriously. And I think that's one of the biggest things that is getting missed out in all the sessions I've listened to since morning. Everything that we're doing is focused on what happens when it gets diagnosed and after. The big issue, why we're all late in getting anything going, and I deal with Health Canada all the time. Funding is always going to be a problem. Money is always going to be short, but I still say we are fortunate we are in Canada. I will never lose faith because I think it's one of the best countries to be, to get health care, to get treatment. It could be worse. We could be part of our southern neighbors. We could be there, and we all know what's happening there. But I think the first line of defense, your GP, I think they need to be trained, educated much more. I think we were referred to a private clinic. We went off to a gastroenterologist who kept calling us back, did scopes, but didn't want to refer us to anybody else. We went to St. Joseph's Hospital, who in Hamilton, for those of you who don't know, and they turned us away. They didn't want to see us. They wanted to send us back for the third time back to the same gastroenterologist who didn't want to see us. Unfortunately, or fortunately, I don't know how I see it in hindsight, I have a fair amount of friends in the healthcare fraternity in Toronto, and it didn't take me a minute once I made a call to get a follow-up in Mount Sinai. I was able to see and get everything I needed within a span of 6 days. So you can imagine a year when I was dependent on the system to see me through, to the point where 6 days later I had to use my own resources, and we managed to get through. She was 37. Nobody thinks a 37-year-old healthy woman has cancer. Neither did I. I travel a lot for work. I was actually supposed to go to Japan when we were told otherwise. I was rather told otherwise no, that she needs to go ahead and get scopes done. Otherwise, I might not have taken it seriously. So that's the first piece. Inpatient, I think we are fantastic. I think being part of UHN, whether it was Mount Sinai, whether it was PMH, the surgical team, the medical oncologist, everybody's fantastic. So I'm not going to name names, but I think they all did their part. And I think we are very evolved on that front. People are willing to answer questions. The staff is excellent. But this was when we were outpatient coming into the hospital. Now, I have got a few more slides because this is more about being a caregiver. So I'm going to try to come back and focus on that piece. And the Kubler-Ross grief cycle, and I use it in different forums at work, and I think a lot of you must have seen this. It's no different about denial, anger, bargaining, depression, acceptance. Each one of us go through it. But I only want to give a little bit of heads up. I know we're streaming live as well, that there's a lot of help out there. Now, we've got MyGutFeeling as well. I think they're trying to reach out. But even though it might not be stomach cancer forums, there are a lot of avenues available out there. Do not try to keep it to yourself and manage it. I think you do need to speak to others. Sometimes family cannot counsel the best. Feel free to reach out to professionals. Feel free, even though Dr. Google might not be the best, but I think you can use Dr. Google to try to reach and connect with others out there who are trying to go through the same challenges. I think it's not a bad bet. And right now, it's even easier. You can just say, OK, Google it, get away from there, and find help. So I think that's going to be an important piece. That's her father, who actually her parents came over and they spent a year taking care of her and helping me out. And I think family plays a big part in that. But of course it's meaningful, it's frustrating. I was raising 2 kids, I was working 14-hour days as an executive at a company. And also the fact that I live about 70 kilometers from here and was driving up and down from Toronto every day doesn't make it easy. But it was important because anybody who's part of your family, your spouse, your children, your parent, they're important, and I think it's an important message to give out there. Don't leave them alone. They might not express it, they're vulnerable, they do need you. And I know that we have other engagements, and I know we always have excuses why we can't. For some people, it's difficult to see that pain and suffering and misery, but I think they depend a lot on that caregiver. It's difficult times when you're not able to sleep. I was sleeping with her in the hospital, going at 5 a.m. back home to get my son up so he doesn't know that I was away in the night. But we did it. We went through it. And it's an important piece because the reason I'm saying it is there is some meaning to it. If they survive, they'll always be grateful. If they don't, you look back and you realize you did something important. I was fortunate, I took almost 6 months off, and my organization supported me. And I was able to give her every minute of the day. And I think that is important because I think I feel fortified in the sense that I think I did what I needed to do. I will kind of spend a few minutes here. Megha, unfortunately, had to go through 3 surgeries in 12 days when she was an inpatient. And I'm not going to blame anybody. I think it was just a draw of straws. I use that analogy quite a bit. Her staples gave way on the 5th day. She went into respiratory failure. She was in the ICU for the longest time. And then she had a kink in her bowels, which had been reconstructed, and she had to be operated again while she was still in the ICU. She managed to fight it all and get home, which is fantastic. Her symptoms didn't get better. I finally decided that, she was declared and deemed cancer-free. It was a curative surgery for her. And I started traveling again. And I still remember coming back in December when her symptoms had totally she wasn't eating for for the 3 weeks almost. And we went to our GP, and we had been going to her all along. And she basically was prescribing her anti-anxiety pills because she said it must be her brain. It cannot be anything else. We finally used her to flag. There's an emergency critical unit in St. Joseph's. We had to wait 2 weeks. I remember I flew back from China, and I took her the next morning to St. Joseph's. We spent 4 hours, out of which 2 hours were spent me detailing her entire history because, of course, we don't have any records that are shared anywhere in Ontario, which is, I don't know why, and I'm not going to try to pretend I would like to know why, but I think a gray area again. After spending those 4 hours there, basically, what I was told is, oh, you got everything done in Toronto at UHN? Oh, you should have gone there. Why did you come to us? So half a day of agony, 2 weeks of wait, and this is what I was told. Anyhow, again, calls to people I knew. We spent a day in the clinic and waiting outside Emerge. We finally got a bed, and we got a TPN in. And Monday, we were again told that again, she needed to have a 4th surgery. She did. And that night at about 10:30 on the 19th of December, I was told she has 90 days more. She came back to the ward on the morning of the 20th, and I could see a distinct difference in the care she was provided because they all knew she's terminal. And it would be untoward on my part if I wouldn't highlight that it is the pressure of the beds, it's the pressure of other cases coming in, which take precedence. She was in that gray zone. She was in the gray zone when she was at home. She was in the gray zone when they prescribed her anti-anxiety pills for what shouldn't have happened. And these are all gray zones. CCAC went away. The surgeons and oncologists did their part. There was nobody to worry about that survivor who was at home, the gray zone. And that's why I highlighted it. Finally, we had some great help. We moved to the palliative care unit at PMH. And they took great care, a lot of counseling, a lot of good help. But again, it's more symptom management at PMH. We still managed to stay there for a month, although they only allow you to stay there for 2 weeks. Don't quote me. I know I'm being recorded. They won't appreciate me sharing this. But they were wonderful. I must appreciate that team. Finally, we made a decision. I actually went and saw personally 5 different hospices between Toronto and Brantford. And I must say this, and I actually wanted to bring this out. The Stedman Hospice at Brantford, that's where finally we took Megha. That's where she spent her last 27th of January is when we moved her there. She passed away on 8th of March. And the care they gave her, the counseling and care they provided to us as a family is par excellence. And I'm sure there's so many more Stedmans that are out there. And I wanted to highlight this and my story about all the lacunae which still exist. I'm part of the system. Like I said, I meet Health Canada more often than I would like to. And I know bureaucracy, and I know they have their hands tied, and I know how much we spend on each area in the province. But in spite of that, I think the only thing I would like to say is we still have a lot of work to do. A lot of work. And Teresa, excellent. Katy, thank you so much. I think you guys are doing a great job. I think Debbie is doing a wonderful job there, and I know she's not doing well right now as well. I fortunately have a common friends with Debbie as well, so I know her there. I didn't reach out to her earlier. But there's a lot of great work happening. I think all of you for being here today. I think I would also like to say thank you on Katy and Debbie's behalf. Teresa's behalf. But don't keep it to yourself. Share your stories. I don't get the time to contribute more. I feel guilty sometimes, but I'm happy I'm here today, and I'm happy I could share my story with you. Thank you so much.
I just wanted to say thank you so much for sharing that. I think sitting in the audience, I have almost like shivers down my back hearing you speak. You can really hear that there's a fire burning in you to make a change for stomach cancer patients. You can really feel that fire just from hearing you speak. So thank you very much. Actually, I'd like to just take a moment right now and say thank you to all the caregivers that have helped their loved ones go through stomach cancer. This is not just a journey for the patient, this is also a journey for the caregiver. So I'd like to just take this moment to give a big round of applause for the caregivers. And I guess this is a great segue. Right now, I'd like to introduce our next speaker, Dr. Dang. He is a medical psychiatrist, and he treats patients with chronic medical issues, such as chronic lung disease, chronic kidney disease, and cancer. He works at St. Michael's Hospital. Dr. Dang is also an educator for medical students and residents in psychiatry. And he was kind enough to speak actually at a previous education session run by MyGutFeeling. And in our session, he discussed anxiety and depression and stomach cancer. He was able to dispel stigma and offer members a way to cope with such a difficult time in their lives. So please welcome Dr. Dang.
Hi, everybody. Thanks so much, Katy and Teresa, for hosting this event, creating this event, creating My Gut Feeling, because this is something that's so needed in stomach cancer. And thank you for having me here as well to talk a little bit about psychosocial effects of stomach cancer as well. It's a privilege to be here and talk to all of you here. As Katy said, I am a psychiatrist. I see people with chronic medical illnesses at St. Michael's Hospital. I know Dr. Bresden Masley quite well. Christine, is that you there? Yes, because I'm embedded in the oncology clinic at St. Michael's Hospital. So over my 11-year career, I have seen plenty of patients with chronic illnesses, plenty of patients with cancer, and heard a lot of different stories. So hopefully I can maintain this talk within 20 minutes because I had an hour and it went over to an hour and 15 minutes when I talked to the My Gut Feeling support group. So I'll try to keep this condensed as much as possible. Really what I wanted to get to talk about today is to discuss a little bit about how stomach cancer impacts patients' lives. Really have you guys think a little bit about what the barriers might be to seeking, accepting, or offering mental health treatment for people with stomach cancer, cancer in general. And maybe touch on pharmacologic and psychotherapeutic treatments for depression and generalized anxiety if we have time. I may just touch on that and as opposed to really go through it in detail. Financial disclosures, I have none. I think it's really important for me to tell you that I do not get any money from any pharmaceutical companies at all, especially in light of the fact that I may talk about medications afterwards. Okay. So, my style is I actually don't like talking, I like having the audience talk. Who better to talk about the psychosocial effects of stomach cancer than people who have seen it or experienced it? So, just want to open up to you guys. What are some of the psychosocial effects that you have seen or experienced with regards to having a diagnosis of stomach cancer? How does stomach cancer change one's life? Sorry? So, depression. So the effect on the mood, like it's a huge shock to get a diagnosis of stomach cancer, a diagnosis of cancer at any age, but often diagnoses of cancer. I look at the room and see how young people are in this room as opposed to primarily geriatric population. So stomach cancer can affect people at any life, and obviously it'll affect your mood. Anyone else? Yes.
Kind of the fear of the unknown.
So all of a sudden your life is just, it's a 180. You're going about life in general, and then whoever would have thought they would have been diagnosed with stomach cancer. And you never would have prepared yourself for that. You never would have done any research around what the healthcare system is, what treatments are. So it's completely unknown. It's a completely unknown thing for anybody. For me, I'm a psychiatrist. I know a physician. I'm in the hospital every day. I know a little bit about the ins and outs of things. The majority of people, they don't know. So there's a lot of anxiety about things that you can't control, things that you don't know. Absolutely. What else have people seen or experienced? Anger. Absolutely. So anger, a lot of questions. It really just changes your perspective, right? It changes your perspective, and it really does open up a basket of emotions. Anything else about how it changes people's lives? Yes? Alienating. Interesting. How so? Go ahead.
No, I was going to say because suddenly you're connected to this whole different environment that people around you aren't experiencing. You're going into hospitals. You're going into all these different areas, and hi. You no longer can share that experience with the people around you on a daily basis.
So your life has changed. You're having all these experiences that most other people around you have not had and have no idea what it's about. People can be supportive in their own way. People can try to be supportive. However, they don't really get what's going on, and it can become quite isolating, which is why organizations like My Gut Feeling are so important, because that feeling of aloneness is huge. So this slide here is borrowed from one of my mentors from before, Dr. Jonathan Hunter, who's a psychiatrist at Mount Sinai Hospital. Talk a little bit about some of the 5 Ds that are associated with potentially a change in experience. So the idea of distance, and something that I see very, very often, the change in interpersonal relationships. I highlighted the idea of feeling isolated. So all these people that may be your support system, friends, family, things shift. And there's going to be stress. We just heard from from a caregiver who is a fantastic caregiver. It really does create a lot of stress on the family unit and on the support network, and people will respond in different ways. So I've heard patients talk about how people who they thought were there for them sort of drifted away or disappeared, and that's extremely stressful. And then also the surprise of people who they didn't expect to come out of the woodwork and be really, really, really key supports, or people who are really close try to provide support but miss the mark. They try to provide support in the best way they can, but it's still not the most effective and doesn't really meet the needs of the patient. So this creation of distance, so the isolation, the alienation that you bring up. The idea of dependency. All of a sudden, people are independent, they're working, they're raising families potentially, they are dependent on the healthcare system, they are dependent on nurses, they are dependent on others, and this helplessness that can happen when you are diagnosed with cancer, along with the unknown. Okay. Disability, especially, so the idea of disability. People going through their lives, they have goals in place, and a diagnosis of stomach cancer just changes those goals. Those ideas that you have for yourself, whether it be academic, whether it be personal, can be disrupted, and that is something that's extremely hard, that can be extremely hard to deal with. Disfigurement. We know what the treatments for stomach cancer can be, including chemotherapy, which can be disfiguring, have a lot of different side effects associated with it. Surgery, also disfiguring, having to adapt to the way the body's going to work after surgery as well. These changes to your physical and sexual self also can be a huge experience. And then with regards to existential issues, when you're diagnosed with cancer, often for the first time, mortality comes into one's mind. Whether or not the life expectancy, whether or not somebody survives for 5 months, 5 years, 50 years after a diagnosis of cancer, mortality does come into one's mind when you hear that word. And existential issues come up, meaning comes up. And that's some of the things that can come up after a diagnosis of cancer and people experience on a daily basis. Okay? I wonder if this would resonate with a lot of people who have had this experience in the past. So, some people mentioned depression, some people mentioned anxiety, isolation. Our last speaker, I'm going to piggyback on some of your comments about, don't be shy to seek out help. Don't be shy to ask professionals for help if you feel you need to. However, there are challenges and barriers, and I know there's screening that's done at oncology clinics. I know ESAS very well, and you look at the screening tool for depression, anxiety, there's a score of 0 to 10. Which is fantastic. It's the question is whether or not there are still barriers that are in place. So, have you seen any? What are some things that have come up? Any idea of some challenges or barriers to seeking mental health care? I can come up with a bunch, but yeah. Stigma. Stigma's a huge one. Stigma is a huge one. And that's what I wanted to sort of talk just a little bit about. These two posters, the left one is from the NHS, the right one on the right is from a stigma campaign for Healthy Minds Canada. It's a bit provocative, and I thought that was really interesting because the word cancer is in here. A lot of people get cancer because they just can't deal with reality. It's a very powerful statement. Who would actually say that? Who would actually say that? But if you replace cancer with depression, anxiety, schizophrenia, any kind of other mental health-related issue, you hear that coming up every so often. A lot of people get depression because they just can't deal with reality. Just sort of suck it up, right? So if we still have this stigma in society, it does become a barrier to potentially even answering a screening tool as truthfully as possible, potentially saying, oh, I can't be depressed, I can't be anxious, so bringing things to the left a little bit more. I also see there's an interesting societal expectation of cancer. There's the idea of, I'm stronger than, how many people talk about fighting cancer, beating cancer? It's fantastic, it's very encouraging, there's a lot of cheerleading that's involved, and I think it's a message that's very important. At the same time, what if you can't, what message does that send? It sends a message that you must be strong, you must be strong. You must be able to beat cancer, you must be able to fight. And there was a slide from our previous speaker about talking about how you're feeling more, I can't remember the quote. I wish I had the slide in front of me, but it was a quote about how you feel more tired than you can be, or feel less able, or less, there's an expectation of being able to do something, yet you can't meet those expectations. So if you have depression or anxiety or a lot of stress, and the society is saying be strong, and you feel you can't meet up to that strong kind of feeling, what does that say? Or admitting that you're, quote, weak, is that something that's really allowed? And then the other barrier that I see as well is potentially access to mental health care services. We know that mental health psychiatrists are very, very limited. Like, the supply of psychiatrists is actually quite limited, and it's going to be even worse in the future. I know our health minister recently, Dr. Eric Hoskins, made an announcement that he's putting in a lot of funding to create more psychotherapeutic resources, because counseling and psychotherapy resources are also lacking. So it's a welcome announcement from Dr. Eric Hoskins that the government is putting money into developing more psychotherapy resources. But sometimes the availability isn't there, and in rural communities and smaller communities, that availability is even more lacking. So if we think about some of the more serious sequelae from a mental health perspective, there's the idea of depression and anxiety. You mentioned depression, feeling depressed. There's feeling depressed and depression, a couple of different things. And the stats are, for people with chronic illness, 1/4 of people with chronic illness do develop depression. And depression, and this is clinical depression. It's a high number, 1 in 4, as opposed to 1 in 9 for breast cancer. I don't know what the incidence for gastric cancer, but 1 in 4 patients with chronic illness will develop depression. And it is frequently unrecognized and untreated. It's not a normal reaction to illness. It's like, oh yeah, you're depressed, it makes sense. It's like, well, not necessarily, not necessarily. And that's where it's important to be able to reach out and seek help, or at least have that dialogue with people. Suicide, desire for hastened death, is much more common in cancer patients than not as well. You think about the feeling of depression, what depression really means. The diagnosis of a major depressive episode is actually, this is from the DSM, it's actually a sustained period of depression, not depressed for a few hours, not at a time. It's sustained depression for at least a couple of weeks. And this is depression, lack of joy in life, and a lack of joy, feelings of guilt and worthlessness, hopelessness, and then some potential changes in physical symptoms such as sleep, appetite, concentration, and also potentially thoughts of death. Not necessarily thoughts of suicide, but thoughts of death as well. And to have that experience on an ongoing basis is extremely distressing. It's suffering, it's mental suffering that's involved. So imagine going through all the treatments of having stomach cancer, or having gone through the treatments and being at the other end and still suffering in a different way. I see a lot of patients with anxiety. And generalized anxiety disorder is actually, the people who tend to have a higher level of baseline anxiety. They worry about lots of different things that, a lot of different things, whether it be health, whether it be finances, whether it be, I think it's like my mother who's, if I don't text message 5 minutes by the time I get home or something like that, they automatically think you're dead or something. That's the idea of generalized anxiety. And it's people who have difficulty controlling worry to the point that it affects their energy, that affects their concentration, they're tense, they're lying in bed thinking about various worries. And there are a lot of people, the incidence of anxiety disorders is also extremely high in the community. Get a diagnosis of stomach cancer, that intensity of anxiety will spike. Okay, so if somebody at baseline has a higher than average level of anxiety and is functioning and doesn't require treatment, that anxiety itself will spike at a higher level. And the reason why it's important is because there's an optimal amount of anxiety that people really need to have to perform well. If you have no anxiety, there's no motivation to do anything. If you have too high anxiety, you freeze. So if you freeze, then you can't actually do the things that you need to do to take care of yourself or to get well. So the idea of treatment of anxiety is to get to the level of anxiety that allows for optimal performance. We know there's screening in clinics. The ESAS screening tool is a 0 to 10 Likert scale. There are more specific screening tools for depression, including the PHQ-9 and the G87, which if people screen positive, then there's questions that need to be asked by a clinician about depression and anxiety. And of course, if suicidal thinking comes up, that is a major red flag. Okay. So, treatment. We talked about counseling, but I'm actually talking about treatment for depression and anxiety, antidepressants and psychotherapy. Do people have thoughts or questions about treatment for depression and anxiety? Antidepressants, what are people's thoughts about antidepressants? What are the things that they've heard about them? Yeah. So there's that feeling that it's a quick fix or it's a cure-all. Is that in a sort of a positive way or a negative way or a mixed way? It's because, absolutely. Is it a cure-all or is it a quick fix or is it an option of fixing versus psychotherapy? And I think it's worth thinking about that. Most people a lot of people I see, for whatever reason, whether it be actually I'm going to come back and say, you think about all the other symptoms on ESAS, whether it be nausea, whether it be fatigue, nausea, decreased appetite, pain, nausea, pain. No one ever says that opioids, morphine is a quick fix or a cure-all. Nobody ever says that anti-nausea medications are a quick fix or a cure-all either. So, when it comes to medications for anxiety or depression, they actually work a lot slower. So, just to sort of tweak that a little bit when it comes to the perception that people still have about psychiatric medications versus other medications. Most of my patients, a lot of patients I see are resistant to the idea of antidepressants for various reasons. We'll talk a little bit about the pros and cons of it. Having said that, when people are suffering, whether it be with nausea or pain or anything else, patients readily accept an anti-nausea pill. Patients readily accept a pain medication. For mental pain, where is the difference? Where is the difference when it comes to mental pain? I'm looking at the time. How much time do I have? Am I over? No? Okay. So I will talk about the pros and cons of each briefly. Antidepressants are safe and effective. Unfortunately, we don't have tests to say which antidepressant may work for which person. The ones that I've highlighted here, there's escitalopram, sertraline, venlafaxine, desvenlafaxine, duloxetine, bupropion, and mirtazapine. I highlight because those are the ones that tend to have fewer drug-drug interactions, and that's why I tend to use those ones as opposed to others. Vortioxetine, I should say, also has drug-drug interactions, but it's brand spanking new. It's not covered by a lot of drug plans, so I tend to shy away from it just for that reason. And at St. Mike's, we have quite an inner-city population as well. These medications are a quicker fix. They're not a quick fix. An anti-nausea medication can work relatively quickly, and even then, a lot of anti-nausea medications don't really, I still see patients experiencing nausea despite ondansetron. Pain medications can work relatively quickly. Antidepressants do take about 4 to 6 weeks to work, which is a lot faster than a lot of other options that you have out there. Side effects are actually very, very mild, usually mild, and they're always reversible. So the temporary side effects that people can get from these medications include a little bit of GI disturbance, including nausea, vomiting, diarrhea, sleep disturbance, increased anxiety, headache. What people complain to me about the most is sexual dysfunction that comes with these medications. Okay. Again, it's not a guarantee, but it's what people complain to me about. And again, people come off of these medications and all of these side effects do go away. The advantage of medications is it's quick. 4 to 6 weeks is pretty quick. They're available. So if you are if you are unable to get appropriate counseling, this is something that can be started right away. Whereas psychotherapy, sometimes you can't start right away. You have to be on a wait list for OHIP-covered psychotherapies, or you have to have funding, money, coverage to be able to access psychotherapies. So they are available, just like anti-nausea medications, just like opioids. They're available, and they are effective, and they do help with suffering. Non-medication-based treatments, which people want to go for, MyGutFeeling is fantastic. There's support groups. There's mindfulness-based cognitive therapy, which I refer a lot of my patients to. There's a fantastic psychiatrist at at Princess Margaret Hospital who runs mindfulness-based cognitive therapy groups for patients with cancer. Wellspring, there's tons that's available. Cognitive behavioral therapy is also an evidence-based treatment for depression and anxiety disorders. The advantage, no side effects. The disadvantage is it requires time, commitment, and effort. A mindfulness-based cognitive therapy course is 8 weeks, and you get out of it what you put in. You need to put the effort in. You need to be able to attend. It's like going to school. It's like learning a musical instrument. You have to be able to put the effort in. Same thing with cognitive behavioral therapy. Same thing with support groups. Most people don't have the time or the energy to go through all three. Otherwise, you'll be spending all your time going to therapy and not spending time living, which is also important. Okay. So that's the disadvantage. And imagine you're going through chemotherapy, you have surgeries coming up, you have all these other medical appointments. Do you really, some people may not want that extra medical appointment per week for cognitive behavioral therapy for an hour that requires a commute and homework at home. So those are the things that are a little bit more challenging about the psychotherapeutic modalities. And availability. Okay? A lot of times in smaller communities, social workers are there, but social workers can be stretched as well. I know our social workers at St. Michael's Hospital, they see a lot of patients. I don't think they have the ability to, provide, cognitive behavioral therapy to every single patient. It's an availability issue as well. Okay. I won't go through cognitive behavioral, like the details, but these are the workbooks that you can always use at home. Mind Over Mood is a workbook for cognitive behavioral therapy, which targets maladaptive thoughts. It targets distorted thoughts that go towards the negative, and you learn how to retrain yourself to bring thoughts to the center. And again, the idea is practicing over and over and over again. There's a lot of homework involved. This is the workbook that I often recommend for mindfulness-based cognitive therapy. It's called the Mindful Way Workbook. It's an 8-week program. The idea behind mindfulness-based cognitive therapy is being able to use sort of the Buddhist meditative techniques to gain more awareness of the present moment, to be able to observe and observe present experience in an accepting, non-judgmental, and more self-compassionate way. Again, a skill that requires practice, a skill that needs to be learned. It's impossible to be perfect at it, but does require a time commitment. Okay. And then there are support groups. Wellspring, Gildas Club, MyGutFeeling, they do exist there for a reason. They themselves are not specific treatments for depression and anxiety, but they create a community. They allow people to share what's going on, to be able to feel understood by people who have similar experiences, to feel less alone. So, which is why I think the support groups are actually extremely helpful. So the take-home messages I want to give to you is that stomach cancer does have significant psychosocial effects, and we've outlined a few of those. A lot of reasons why depression and anxiety are underdiagnosed and undertreated in cancer in general as well. Do think about how to encourage patients, people to seek out professional advice if there is that mental pain that is associated with a diagnosis or the cancer journey. That mental pain is like any other physical pain. There are interventions that can help, and medications, antidepressants are safe, effective, convenient, and available. Psychological treatments, no side effects, no physical side effects, but the side effect is the effort, the energy that is required to seek it out and to participate in those treatments. The gold standard for depression and anxiety is to do both. treatment can improve patients' quality of life. I'm just thinking about a patient right now, as I finish off, a patient who I've seen relatively recently, a high-functioning person, has career-driven, sort of gets promoted, keeps on moving up the ladder in her workplace, and has a young family at home. There's a recent diagnosis of metastatic cancer, and was significantly depressed. I saw her in the oncology clinic, and she was completely in tears constantly. She had suicidal thinking. She was not eating. She was not enjoying anything in her life at all. Wasn't able to interact at all with her children. And she full well knew that she was going the palliative care route at some point. And a simple intervention of an antidepressant, it was mirtazapine in particular, which also has the advantage of increasing appetite and increasing weight. Within 3 weeks, she had started feeling better. And literally the second appointment that I saw with her, the tears were not tears of sadness. The tears that she had were tears of, being able to actually experience life again and actually be able to pursue her current goals of spending more time with her family, with her kids. And with somebody who has a limited timeline. Again, we don't know what the timelines are with cancer. Some people die quickly, some people survive for many, many, many years. But when there is the potential for a limited timeline, you want to be able to spend that time with the way that you want to. And with depression, anxiety, that's not something that you want to have to delay the pursuit of one's goals. These are some references I have as well. I hope this is helpful. Thank you very much for listening.
Thank you, Dr. Dang. So we are running a little bit behind. So in the interest, if everyone's okay, in the interest of time, we're probably going to cut the afternoon break. And we can sort of at least do the panel discussion, and we can still have the snacks afterwards if people want to stay. So then our next speaker is Denise Gabrielson. And I have to say that what she's going to be speaking to is probably one of the hottest topics in our groups every month, and questions that we get all the time, because she's a dietitian, and that is so crucial for us. So Denise Gabrielson, I better put my glasses on, is a registered dietitian at St. Michael's. She's worked in oncology and hematology since 2007. She's currently the primary dietitian for the medical daycare unit, providing nutrition care to outpatients receiving treatment for gastrointestinal cancer, breast cancer, genitourinary cancer, lung cancer, and hematological cancers. Denise recently completed her master's in nutritional sciences at U of T on nutritional status in patients with gastrointestinal cancer. Yay! And she's also published and implemented research on nutrition screening in outpatient oncology in order to improve access to nutrition care during cancer treatment. Denise Gabrielson.
Good afternoon. So this is a very long topic, and I could talk about food and nutrition forever, but there's a limited time, so I'm only going to be able to touch on a few things. But I wanted to start with talking about why nutrition is important. So nutrition is important whether you have just been diagnosed, whether you have just had surgery or are about to undergo surgery, whether you are going through chemotherapy or radiation therapy, or whether you're recovering from treatment. So eating well helps to maintain strength, and we're talking about physical strength, maintains body tissues such as muscles and helps to rebuild damaged tissues, protects against infection, and can also help to minimize or manage side effects during treatment. There's also research showing that people who are well nourished are better able to maintain their treatment schedule or have fewer treatment delays. It can also help to optimize quality of life, so mental, physical, emotional well-being. Dietary change is not easy. Nutrition and eating well can be important, but it's also very hard to change our ways. So many of us have food habits that have been built over a lifetime. We also have different relationships with food. We may eat solely for nourishment. We eat when we're happy. We might eat when we're sad or anxious. We also use food for family celebrations or gatherings with friends. This complex relationship with food can make it very difficult to make dietary changes or find a new normal. It means making alterations in habits that have been built up over a very long period of time. It may mean making temporary changes to manage side effects or to stay strong during treatment, or it can mean longer adaptations or alterations to your ingrained habits in order to learn to enjoy food again, or to learn to have a positive relationship with food again during treatment and after treatment. Nutrition information can be confusing. So we've talked a lot about Google today. When making dietary changes and finding a new normal, not only do we have to think about symptom management and working in opposition to learned dietary habits, but we also may receive conflicting nutrition messages from a variety of sources. This can be confusing, and it may put additional pressure to eat a particular way and unnecessary pressure to eat a particular way when you're already faced with challenges with eating well. So what is eating well, and what do we consider a healthy diet? So a good place to start is cancer prevention guidelines. So these are from the American Institute for Cancer Research, and these guidelines can be applied at all stages of treatment, whether before, during, or after, with maybe some tweaking here and there depending on how you're feeling. Some of these include maintaining a healthy weight, so that also means not being overweight but also not being underweight. Be physically active for at least 30 minutes a day. So, this makes a lot of sense for cancer prevention, but as mentioned earlier with Dr. Mike Evans' video, there's research to show that regular physical activity during treatment can actually help with treatment-related fatigue. It seems counterintuitive that, you've had chemotherapy, you're tired, get up and move, but it can certainly help. Avoiding sugary drinks and energy-dense and low nutrient-dense foods, so things that offer a lot of calories but not a lot of nutrition. Eating more of a variety of fruits and vegetables, legumes, whole grains. Limiting consumption of red meat and processed meat. And if you consume alcohol, limiting alcohol intake. Limit consumption of salty foods and foods that are preserved by salting. And one of the messages, again, with different sources of information out there, is not relying on nutrition supplements as a way of preventing or treating cancer, and try to rely on food when possible. So a balanced diet provides energy from protein, carbohydrates, and fat, and also provides important nutrients such as vitamins, minerals, phytochemicals, and water. So you're going to be told during treatment to make sure you're drinking enough water. So protein is needed for growth, repairing body tissues, maintaining physical strength and muscle mass, and also recovering from treatment and keeping the immune system healthy. Carbohydrates are probably the major source of energy for the body, and those can come from whole grains, legumes, fruits and vegetables, starchy foods like bread, cereal, pasta, or anything made with flour. The simplest type of carbohydrate is sugar, so we'll talk a little bit about sugar later on. Fats are also a significant source of energy and can also be an easy way to add extra calories when needed. Generally, it's recommended to choose monounsaturated and polyunsaturated fats. Phytochemicals are chemicals that are found in plant foods. So these are the things that make fruits and vegetables brightly colored or give different foods very strong odors. And those have been shown to have positive effects with certain diseases. So examples would be beta-carotene found in carrots, lycopene found in tomatoes, anthocyanins, which make blueberries blue. So these can also have health benefits. But again, like I said, it's good to get them through food when possible rather than supplements. An easy way to ensure that you're having a balanced diet is to think of your meal as a plate and filling half of your plate with vegetables and fruit, just over a quarter of your plate with grain products or carbohydrate-rich foods, and just under a quarter of your plate with meat and alternatives. So what if you don't feel well and your plate looks more like this? So what do we do about that? So recognizing that nutrition is very important during treatment, the general recommendation is to continue with a healthy diet, but it's also important to acknowledge that everyone's needs and abilities may be different depending on where they are during their treatment trajectory. And really the main message is to eat as well as you can. So now we'll talk about some challenges that might make it difficult to stay well nourished. So weight loss is a big one. Malnutrition and weight loss is present in more than 70% of people diagnosed with stomach cancer. Severe weight loss has been linked with a weakened immune system, longer healing times, a greater difficulty with side effects of treatment, so that means maybe having side effects more often or more severe side effects, and also limited ability to do daily tasks or usual activity and decreased quality of life. Some general tips on dealing with weight loss. So one of the things we talk about is optimizing calorie or energy and protein intake to keep weight stable. So some of the ways to do that is avoiding unnecessary diet restrictions. So I definitely encourage people to speak with their healthcare teams about diets that they may have heard about or diets that they're interested in. What is the evidence around those diets? Will it really help you? Or is there a potential for harm? Also, if you're following any special diets for management of any other chronic diseases, maybe there's an opportunity to maybe liberalize some of those dietary restrictions to make sure that you can continue to eat well. Eating small, frequent meals using calorie and protein-rich foods can certainly help, particularly if you don't have a lot of room or you don't have a stomach. Recognizing that at times during treatment, eating is going to feel like a chore, especially you are going to probably hear very often, you know, eat 6 small meals a day. And so it might feel that you're having to eat every 2 hours or constantly thinking about eating or planning what you're going to eat. So it can definitely feel a bit like a burden. Limiting low-fat and low-calorie foods most of the time, or combining them with high-calorie or high-protein foods. So, for example, having a high-fat yogurt, or if you're having a piece of fruit which doesn't have any protein and is not very high in calories, pair it with a handful of nuts. Prioritizing high-calorie and high-protein foods at meals, particularly if you feel full very quickly, can help to make sure that you get in those calories and that protein that you need. And some people may need to eat by the clock rather than waiting to feel hunger. So often hunger cues are absent. You don't have that reminder to say, oh, it's 12 o'clock, wow, I'm starving, it's time to eat. It may mean using your smartphone and setting an alarm and saying, okay, it's lunchtime, okay, 2 o'clock, I should stop and have a snack. These are just some examples of high-calorie and high-protein foods. So high-calorie foods tend to be concentrated in fats, and these can be healthy fats, so things like avocados, oils that you can add to your foods. High-fat dairy products is also a source of calories, and dried fruit can be a good source of calories because all of the water has been taken out, so it's very concentrated. High-protein foods include meat, fish, eggs, legumes, and some examples of both would be cheese, so it has protein and it's high in fat, so it provides calories as well. And nuts are also high in healthy fats, but provide protein, and yogurt. So another symptom that's very common, depending on if you've had surgery or not, is dumping syndrome. So dumping syndrome is a side effect from a partial or total gastrectomy and can affect anywhere from 1 to 75% of people after surgery. It is essentially the result of loss of storage space in the stomach and fast emptying of very concentrated stomach contents into the small bowel or intestine. It can be classified as early or late dumping syndrome, and some of the symptoms include flushing, feeling dizzy, nausea, weakness, vomiting, hunger, fullness, I can't remember, dizziness, and diarrhea. So it can be aggravated by a high sugar content of food or fluids, and also could be aggravated by taking fluids with meals. Symptoms are usually the most prevalent right after surgery and generally subside over time. There's a very small percentage of people in which the side effects of dumping can last longer. So some general tips. So you'll hear this a lot. Eat 6 or more small meals a day. Eat slowly and chew food thoroughly. And sit upright while eating. Avoid or limit high sugar foods, so that can cause a lot of water to rush into the bowel, and that makes things go through faster. Limiting fluid intake at meals and drinking fluids 30 to 60 minutes before or after meals can help. Sometimes people find laying down after a meal or including protein with a meal or choosing high fiber foods when possible can help to slow that transit time through the gastrointestinal system. Nausea and early satiety are other common symptoms associated with stomach cancer. Some more tips. So eating well when you feel your best and eating whatever you tolerate the best. So if you feel like you could only tolerate pancakes for breakfast, or sorry, pancakes for dinner, then have pancakes for dinner. Avoid foods and smells that bother you. If you have help around the house, get someone else to do the cooking and stay away from food odors. Often room temperature foods or cold foods are easier to tolerate. You don't have the odors from foods wafting towards your face that you get with hot entrees. Avoid foods that are overly sweet, greasy, or spicy. Take your time eating, and if you don't have dumping, staying upright an hour after eating can help to prevent nausea and vomiting. Eat small meals or snacks throughout the day, especially if you feel full early. That can help. One, it's easier on the stomach with nausea, and if you feel full quickly, it helps to sneak in those extra calories and protein to keep your weight stable and your nutritional status stable. And then sipping on liquids between meals rather than having them with meals can ensure that you don't fill up on low-calorie fluids instead of the energy, protein, and nutrient-dense foods at your meals. So finding a new normal not only means, strategizing and learning ways to deal with symptom management and staying strong during treatment, but it could also mean learning to navigate meals in the home and away from home. So some tips for at home include stocking the kitchen with foods that are easy to prepare or require no preparation, and foods that are well tolerated or that you feel safe with for when you're really feeling unwell. Preparing large batches of meals and freezing in small portions can help to ease the burden of food preparation, but can also allow you to rotate through different foods as you have changing preferences and changing tolerances of different foods. Trying new foods often, and keep a list of foods that work well. So maybe have a safe list of foods that you tolerate really well. Using smaller dishes can help meals feel more manageable and less overwhelming. So sometimes when you really have no appetite and you don't feel like eating, a big plate of food just seems overwhelming and you're just turned off of the meal. By putting things on small plates, it feels like it's more manageable. When you get through it, you feel like you've achieved something. Keep meals simple, particularly if you're having treatment-related fatigue, and ask for and accept help. Eating away from home can be another issue. With the holidays coming, there's social gatherings, things like that. Discuss dietary needs with friends and family. If you're going to someone's house, if you feel comfortable, offer to bring something for yourself that you know that you'll be able to tolerate well. If you're going out to a restaurant, look at restaurant menus ahead of time and try and identify something that you feel that you can handle. And avoid overeating, eat slowly and chew thoroughly. So this, may be easier at home. When you're out and about in a social situation, sometimes people forget to do that. And it's okay to leave food behind. And then try to time eating out for when you feel the best. So you may find that as the day progresses, you feel more and more full. So it means if you want to go out somewhere, maybe going out for brunch or maybe going out for lunch instead of dinner. I'm just going to touch on a couple of common things that come up when I first meet people in clinic. So one of the big questions and concerns that I get is, does sugar feed cancer? So all cells, including all healthy cells in the body, as well as cancer cells, use sugar, or glucose, which is one type of sugar, as energy or fuel for the body. So sources of glucose would be carbohydrate-containing foods. So healthy choices for sugar would be fruits, vegetables, whole grains, and dairy products. And other sources would include sugary drinks, candies, cookies, and cakes. So at the current time, there doesn't appear to be a direct relationship between sugar and cancer in saying that if you eat sugar, your body will, the tumor cells will preferentially get those sugar molecules instead of the healthy cells in your body, or that they'll make the cancer grow more rapidly. The evidence so far points to an indirect connection between sugar and cancer. So high sugar foods can lead to an excess body weight or excess body fat, which has been linked to a higher risk for cancer. And also high sugar foods tend to be low in fiber and other nutrients. And these foods may displace more healthful choices that contain nutrients such as those phytochemicals and vitamins and minerals and whole grains or fiber that have protective effect on cancers. I'd also wanted to touch on navigating nutrition information. So I talked about at the beginning that nutrition information can be confusing. There's lots of conflicting messages out there. So how do we navigate this information? So Jan talked about having his wife as a filter, which is good, but learning to be your own filter can be helpful as well. So we're bombarded with information from many different sources. So experts, healthcare teams, friends and family, government agencies, interest groups, the internet, news reports, and studies. One of the best things is to read information carefully. We all want to look at things that might help treatment outcomes, help with quality of life, help manage side effects, and there's lots of information on food and dietary supplements. So some of the things to look out for that are red flags. So when dietary supplements or diets are referred to as miracle or breakthrough, whether they're supported by anecdotal evidence or testimonials, or whether they have hefty claims or claims that may be too good to be true. Progression of nutritional science is very slow. It relies on more than one study showing similar results to change practice rather than the results of a single study. So we don't usually recommend making dietary changes or starting a new supplement based on the results of one study. And it's important to evaluate the source of information. So are they selling a product? Who is writing the information and what are their credentials? And is the information reviewed by experts? And is the information up to date, or has this been something that's been circulating on Facebook since 2005? And discuss this with your healthcare team. I encourage patients, if they see something and they're not sure about it, they don't know how to interpret the science or a news media report, I encourage patients to bring in an article or email me a news report, and we can go through these things together. One of the biggest take-home messages is similar to treatment regimens, one size does not fit all. So healthy eating may need to be adapted to your individual needs. Don't be too hard on yourself. You are learning a new way of eating, and it takes a long time. Make a list of safe foods. So if certain foods are not tolerated, give it more time and try it again down the road. Symptoms that may affect your ability to eat may be worse right after treatment, but they will get better over time, although the time is different for everyone. And eating is a very social activity, so let friends and family know that you need smaller portions, and don't be worried about leaving food behind. And just one last take-home message is, I like to think of nutrition as an integral part of cancer treatment and recovery plan. So you may view nutrition as a source of nourishment, as a way of socializing, but at times you may also wish to think of nutrition and eating well as a tool in your cancer treatment toolkit, or a skill that has to be learned and practiced often. So if I can give an analogy for music, doing scales on the piano very much seems like a chore. No one really likes to do it. But as you learn and practice, you get the ability to make beautiful music in the end. So while eating may often seem like a chore, as you practice and find strategies that work for you, you will become or stay well nourished, and that can improve your quality of life. And I also encourage, you know, not being able to touch on everything today, I encourage you to seek out your dietitian on your healthcare team to have these conversations and dialogues about nutrition information that's out there. But these are some reputable resources for nutrition information. So in your bag, you'll find 2 Nourish handouts that are related to eating well after treatment, but there's also some information about eating during treatment on the Nourish website. Canadian Cancer Society, Eat Right Ontario is similar to Telehealth Ontario, but it's free access to dietitians over the telephone. Dietitians of Canada, the American Cancer Society, the American Institute for Cancer Research, and also Goes Down Easy is a book that was prepared by dietitians at Princess Margaret Hospital that has lots of very easy recipes that are organized by what symptoms you might be experiencing. So it's a great resource as well. And then I think we're saving questions for the panel.
Thank you so much, Denise, and I'm sure there'll be lots of questions on nutrition. Our next speaker is coming off of, I think he said, a 22-hour surgery. So I'm so happy that he made it here to speak to us. Dr. Savtaj Brar is a surgical oncologist at Mount Sinai Hospital and assistant professor in the Department of Surgery at the University of Toronto. Dr. Brar has a clinical focus in the management of gastric cancer, complex gastrointestinal oncology, and soft tissue sarcoma. His academic interests include education, health policy, and economic evaluations in surgery. Dr. Brar is a graduate of the medical school at the University of Western Ontario and obtained his residency training in general surgery at the University of Calgary. One of his primary goals is to improve care for patients with gastric cancer, and that's why we love him. Dr. Savtaj Brar.
Hi guys, I just wanted to say thank you for the invitation to Teresa and Katy and the organizers, and if we can just give them a round of applause now. It's such a great day of speakers and so much important work that they do. Just here. Yeah. So, as Teresa said, my name is Sav Brar. I'm a surgical oncologist that works at Mount Sinai. I work very closely with Dr. Coburn on improving or helping to improve care for stomach cancer. During my training, I spent 2 months in Tokyo, Japan, working with one of the busiest stomach cancer surgeons in Japan, because there are countries in the world where stomach cancer is very common. China, Japan, South Korea, and in those countries they have surgeons who all they do is stomach cancer as the only operation that they perform and the only patients that they treat. And so as part of my training, I went there to sort of see what they did and how they approached stomach cancer patients. And to give you an idea of how many patients they see, in the hospital in Tokyo, which is not even as close as busy as the hospitals in Korea, they saw they operated on 20 stomach cancer patients per week. And in a very busy hospital in Canada, we would see maybe 30 in a year. So the volume of surgeries that they do is very high. The level of expertise is great. And this is just a picture also, some of the secondary benefits of going to visit other places is cherry blossom season in the Nakameguro Canal. So if you do get a chance to go to Tokyo, try to go during the spring, because it is actually a very, very beautiful place during the cherry blossom season. We have some cherry blossoms in High Park too. I guess that's close second. So I was asked to speak about surgery for stomach cancer, and you know, it's a complicated talk, but I also wanted to talk about the role of surgeons in the care of patients with stomach cancer. And I think myself and Dr. Coburn call ourselves surgical oncologists for a reason. We don't think it's just about the surgery. We think it's about helping to take care of patients with cancer throughout their journey. And specifically in stomach cancer, we're intricately involved with the diagnosis, the staging because of the investigations we do, and obviously the treatment both of curative cases and palliative cases. And we like to work in a multidisciplinary way with our medical oncologists, our dietitians, our radiation oncologists to try to come up with the best treatment for patients who have stomach cancer. And one of the ways patients often ask, what stage am I? And when we're trying to figure out what to do. And the way I've simplified things for myself is to think of stomach cancer independent of stage overall, but to think about early stomach cancer, advanced stomach cancer, and metastatic stomach cancer, because sort of everything is based on one, if you fit in one of those boxes. And in general, for early stomach cancer, which is actually quite common in South Korea and Japan because of their screening, but very rare in North America, surgery is really considered the only treatment, and sometimes not even a full surgery. Sometimes you can just remove the cancer if it's a very small, very early cancer with endoscopic procedures. There's no need for chemotherapy, and there's no need for radiotherapy. Advanced stomach cancer, which is what we mostly see here, is a bigger surgery and often needs chemotherapy and chemoradiotherapy. And then in the metastatic setting, as a surgeon, we find our role is mostly in support of situations where a patient has symptoms that may require surgery to help them, but there really isn't a role for surgery as a mainstay or a core part of the treatment. And so I'm going to talk about advanced gastric cancer because that's the patients that we see more often. So, I'm a very visual person. I wasn't good enough in art school to become an artist, but I like to do drawings to help patients understand what's going on. And there's a lot of terms that we use to describe stomach cancer operations. But, sort of the surgery that is also called a distal gastrectomy. It's called a subtotal gastrectomy. And what that means is that we take a good portion of the stomach and reconnect the small bowel to the stomach with what we call a Billroth to anastomosis. And when I asked Teresa and Katy what I should talk about, they said, why don't you talk about what's new in stomach cancer surgery? And, as technically savvy as myself and Natalie Coburn are, there's not really that much new. So Billroth described this joint, which what we do, in 1885. So it gives you an idea of how slowly some things will change in stomach cancer. It's not the only thing we do, but this is a very, very old surgery that we do. So the principle is if the tumor is in the distal part of the stomach, that we need to get at least 5 or 6 centimeters proximal or upstream from the stomach so that the cells that we can see and the cells we can't see are all removed. Because the most important thing for a stomach cancer operation is obviously that it's safe, but also that we remove all the cancer cells and that we don't leave any behind. And sometimes that's impossible, but our goal is to make sure that we have what we call a good margin of tissue. And then when we reconstruct the bowel, if there's enough stomach left over, function is actually pretty good. And there's something called the near total gastrectomy, and I've had many patients say, if you can leave just a little bit of stomach, it would be very, very good. And what we know is that when you have very little stomach left, the function is actually very, very similar to if you had no stomach left. But it does make surgery sometimes a little bit easier. And I think a lot of people just have just a fixation on the idea that having a little bit of stomach is better than having no stomach. And we know, we've studied this, and we know that the function is about the same, but we understand. And so when we can, we try to leave a little bit of stomach. But again, the important thing is the margin. So if it's too close, we don't want to get too close to the cancer cells we can't see and leave cancer cells behind. So often the decision is made at the time of surgery, but sometimes beforehand, depending on the location of the tumor and how the surgery goes. And then we talked about the total gastrectomy and what we call a roux en Y. And the reason why it's called a en Y is a guy named Roux did it. He's a Swiss surgeon, and the bowel kind of looks like a Y when you're done. But it really doesn't look like a Y when you're done, so it's a funny name for this surgery. And again, this is I think 1897 was this surgery was first described. So things move slowly in our world. It's not like the chemotherapy world where they have new fancy medications every 6 months. But this is the joint that we do when people have a total gastrectomy, and often the near total gastrectomy as well. A lot of talk goes into the D2 lymphadenectomy, and I mean, sometimes it's hard to understand. Sometimes it's considered standard of care, sometimes it's not, and it's been very confusing in the surgery world to figure out where the D2 lymphadenectomy stands. So in Japan, it's considered the standard of care. So they won't even do a clinical trial where they test the D2 lymphadenectomy because it's so clearly the standard of care that's what they would do for every advanced stomach cancer. And we know that we should remove at least 15 lymph nodes, which doing a D2 lymphadenectomy is very helpful for. But in North America, it's considered an option if you have advanced stomach cancer, because there is certainly some evidence, though not black and white evidence, that it's better for patients if they have a D2 lymphadenectomy. And we know that in advanced centers with lots of expertise, it can be done safely. So it is an option for surgeons to undertake. This is sort of a diagram of the stomach. So now the stomach is flipped upside down. And when we mean a D2 lymphadenectomy is we're looking to get lymph nodes from around the stomach. First thing is to get them for staging so the pathologist can look at the lymph nodes under the microscope to see if there's any cancer cells, because that goes into part of the staging, which helps us decide on treatment, but also give us an idea of what the expected outcome or survival would be. So the blue nodes are what we call the D1 lymph nodes. So those are the lymph nodes just right around the stomach. And this is what most surgeons in North America would have been doing until a few years ago. And then the D2 is quite an extensive a lymph node dissection. So it includes all the blue nodes, all the orange nodes, and these red nodes here and here. And this little red thing is the spleen. That's the pancreas. And that's the duodenum. And so it's actually a very technically difficult surgery to do. People in Japan and South Korea train extensively to do it. And so myself and Dr. Coburn have gone over to those countries to learn how they do them. And we're actually, and I'll talk about that at the end, we're actually starting a course here that we're going to hold in June to help. We're bringing a Korean surgeon and a Japanese surgeon here to help train us in this technique further to improve how well this surgery is performed in Ontario, because we know it's very, very difficult to do, and you need lots of practice. And so we're trying to improve how well the surgery is done here in Toronto and Ontario and Canada-wide. So as I said before, there's still a debate about whether or not to do it, but we do know in high-volume centers, hospitals where a lot of these surgeries happen, and surgeons that do a lot of them, the surgery is safe and has good outcomes, and we think probably is better for patients, though it's hard to prove in any studies that have been done in the West. So how do patients do after surgery? So almost a quarter of patients have some sort of complication related to surgery. And we know that about 1 in 25 patients will die as a result of the complications from surgery. So I think this is sort of one of the things that has been the most striking when I started learning about stomach cancer is there's operations out there that are considered very dangerous and have to be done in high volume centers. A Whipple procedure or a pancreas cancer procedure, there's only 4 hospitals in Toronto that do them. Lung cancer operations, you have to go to the big centers to do them. Cardiac bypass surgery, you have to go see a cardiac surgeon and you have to go to the CVICU afterwards. And in those surgeries, the mortality or the likelihood that you would die after the surgery is somewhere around 2%. And we know, Dr. Coburn, was it now 4 or 5? Yeah, so 2.5 for Whipples, which is considered the hardest operation in general surgery, and 4% for stomach cancer. So this is a very difficult operation done in very sick people, and it's under-recognized as a serious operation, I think. And one of the goals of education in our medical schools and our residencies is to try to increase awareness about the disease, increase the ability of surgeons to treat patients with stomach cancer, but also to raise awareness of how serious not only is the disease, but how serious the surgery is. And it's not just us. These are 30-day mortality from surgery from other countries, and in high volume centers in Japan, it's like 0.1%. So their patients are healthier. They're like, a third of my weight, and they're early stomach cancer, so they're often not as sick. But, somewhere in 4 to 7% is the risk of stomach cancer surgery in the Western world. So all that stuff is important, but the questions that patients have when they're undergoing the surgery is what will my quality of life be? And there's lots of studies in this, and we know that quality of life after gastric cancer surgery is a mix of two factors. So there's surgery itself, and then there's having cancer. And we know now, there are patients who have prophylactic gastrectomies for genetic disorders that I think Melissa touched on before. So we know in patients who have their stomach removed, who don't have cancer, that quality of life returns to the baseline at about 1 year after surgery. So even in the best case scenario, when you don't have cancer, it takes about a year for your quality of life to get back to what the level was before surgery. And I tell patients is the first 3 months can be very tough, and then things level out between 3 to 6 months, and then by about a year, your quality of life will get as close to normal after the surgical part as is possible. We know the cancer part of it also adds another layer to the quality of life, and there's been lots of studies about this, and I think the thing that we talk about is overall quality of life, and I think one thing that patients initially focus on is eating, and how am I going to eat without a stomach, and where's my nutrients going to come from, and do I have to check this, and do I have to check that, but the thing that's under-recognized in all surgical patients, but especially gastric cancer patients, is how much fatigue. And you guys, if you've had the surgery before, had treatment before, know this. But I think we do a bad job of warning people that it's going to take months and months, if ever, for you to get the wind back in your sails after this type of surgery. And that's true not only if you have cancer, but also in the prophylactic patients, that there is it takes a very long time to heal. It takes a lot of energy to heal, and it takes a long time for you to get the step back. So, 60% of people right after surgery complain about severe fatigue, and that 18 months afterwards, only about 20% of those, so 60 goes down to 40%. So still 40% of patients, 18 months after surgery, still complain about fatigue being a severe limiter in their quality of life. So it's something that we should do a better job of warning people. And if you're feeling fatigued after surgery, even a long time after surgery, it is normal. It is expected, and it is not something wrong with what's been going on. So what's new? Laparoscopic surgery has been developed in stomach cancer surgery. So it was first done in the 90s. It's also known as keyhole surgery. So we use a camera and ports instead of a big incision to remove the stomach. And we know that there's less pain, reduced blood loss, shorter hospital stay, and quicker recovery. We know in big studies from Japan and South Korea that it's safe and equivalent to open surgery. We know probably that it's about the same for advanced cancer, but we don't have that same level of evidence. So doctors like to prove something works beyond a shadow of a doubt before they can say, oh, it's the same. I think probably there's no real meaningful difference. And so I offer patients both open and laparoscopic surgery for advanced stomach cancer, and some patients actually pick the open surgery because they're worried that laparoscopic surgery may not get everything. But everyone has their own priorities, and I think the patients obviously should be at the center of the decision making. There was, however, a recent study that showed that survival 3 years after laparoscopic and open surgery was equivalent, and so we have our first real evidence that it's about the same. So now when I have conversations with patients about their options, I can say, as far as we can tell, the outcomes are the same. And so it really is a patient-centered decision about the removal, the approach. And then, often patients ask about robotic surgery. So in the States, robotic surgery is the rage. And there's some big cancer centers in the States where they went from open surgery, did a little laparoscopic surgery, and then went right to the robot. To be honest, I am not trained in the robot, so I'm also not paid by anyone who makes the robot. But I can say that we know from studies in South Korea mostly that there really isn't a difference between laparoscopic and robotic surgery. So we know patients have better recovery, but there doesn't appear to be any increased benefit either from patient quality of life or from the outcomes of the cancer surgery from the robot. But we do know that it's a longer operation and increased cost. So as stewards of the healthcare system, I'd probably say I will never be a robotic gastric cancer surgeon, but you never know. So early gastric cancer, just to talk about quickly, up to 50% of patients in Japan have early stomach cancer. They have screening, so they have a high enough stomach cancer incidence or a rate of stomach cancer in their population, so it's treated like breast cancer and colon cancer and prostate cancer. So they have screening that starts at the age, I think in Japan it's 50, in South Korea it's 45. And they either do endoscopy or a barium x-ray test, and early stomach cancer is found. And we know that for some of these patients that we can do, so I've seen them do this. They're like ninjas. They have these little scopes, and they you know, everything looks like so abnormal. I'm like, I don't know what they're doing. And then when they're done, there's like a perfect circle where the stomach cancer was removed. It's fantastic. And then they can test the specimen afterwards to see if it really is something that doesn't need surgery. So many patients will have endoscopic resections, either what we call endoscopic mucosal resection or endoscopic submucosal resection. And the idea is that for very early stomach cancers with what we call good features, so that's non-aggressive looking cancer, and there's that you can do this because there's a very low rate that the stomach cancer will go to the lymph nodes, so that we don't have to check the lymph nodes or take the lymph nodes out. So we think in those patients, the lymph node metastasis rate is less than 3%, and you know, unfortunately for us, not many patients in Ontario at least have early enough gastric cancer that would fit this. So maybe somewhere between 5 or 10 patients per year would qualify for this. So it's a very rare situation for us. But we do have patients who have early stomach cancer that may not need the D2 lymphadenectomy because it's early enough where the likelihood of it having spread is low. And so you can do other operations that they describe in Japan. And I saw them do this. They're very, very good, is just taking out the middle part of the stomach, which we don't normally do for stomach cancer, or just taking out the top part of the stomach, which is also something that we don't do typically for stomach cancer that's advanced. And then just briefly on metastatic disease. So when stomach cancer leaves the stomach and the immediate lymph nodes around the stomach, it's considered metastatic disease. And what that means is that as much as we as surgeons are known for our egos, we have to be humble in knowing that our surgery will not be able to remove all the cancer cells. And in reality, if you can't remove them all, then you shouldn't try to remove some of them, because you get all the risks of the surgery, which we know are plentiful, and all the quality of life problems that come after surgery, but none of the benefit. So when we do surgery in the metastatic setting, it's in the palliative situation. And palliative, I think, has a strange connotation. I think lots of people think of palliative as an end of life, but really the word means to make better. And it was actually a surgeon, a urologist in Montreal, who came up with the term and opened the first palliative care unit in North America, actually in the world. And so there are surgeries that can make things better, so symptoms better, and one of them is a bypass surgery if someone has a blockage from stomach cancer but can't have a gastrectomy because they have metastatic disease. And occasionally, though very rarely, sometimes we do a surgery when someone has very bad bleeding, even though they have metastatic disease. There's other options for these situations, including a stent or radiation for bleeding. So in the absence of symptoms, there's really no role for surgery in patients with metastatic stomach cancer. And it's a question that we get a lot. And unfortunately, many patients come to our clinics who we discover to have metastatic disease. And it is obviously a very distressing situation for the patients, but it's also something that we feel helpless about as well. So I know we're a bit behind time, and if you guys have any questions, I'm happy to answer them in the panel afterwards. But again, I would like to thank Teresa and Katy for the invitation, and thank you to all of you for coming, because it really is helpful for us to remember why we do the work that we do, and the impact this disease has on people's lives and their families' lives. It's a very important reminder for us that at the end of the day, this is about you guys and what you guys are going through. Okay? Thank you very much.
So our last speaker of the day, unlike a lot of the people that you've heard from today, is actually fairly new to My Gut Feeling. She connected with us when we first announced that we were having a conference, and she made a great comment saying, "Oh, it's about time." So when we connected with her and we heard her story, we just knew that she had to be one of the speakers here today. Lina is a 17-year stage 3B stomach cancer survivor. She was lucky, yeah. She was lucky enough to marry her best friend, Tiano, and they are parents to a 3-year-old daughter, Liana, who's joining us here. Lina is working on publishing her first book, DNA Moments. So I really want to welcome Lina.
Help me with this? Okay. Wow. I swear it's been 17 years and, oh no, my presentation's not there? I can talk. I don't get very emotional, but man, today I have shed a lot of tears. It still is very real, even after so many years. That's okay. We can do it without slides. My slides are a little bit more impactful though. Not, no, that's okay. I'm going to try to keep it light. It's been a very informative, but a very heavy day as well. So I am going to share my story because it was very interesting 17 years ago being diagnosed. So a lot of things have changed, but I also want to focus more on the now and provide some hope. Oh, should I wait or? I'll just pretend like the slides are up there. So slide 1. I had a picture, and it was just the number 2001. And what I was going to say is if I asked everyone in this room what happened in 2001, I would bet money that every single person would have the exact same answer. And it's unfortunate, but in 2001 was September 11. And I think most of us will remember that year because of that. However, for me, in 2001, what I wanted to highlight were some things that happened here in Canada. And so my numbers I took off of the Canadian Cancer Society website. But in 2001, there was 134,100 cases of cancer that was diagnosed. And of those, 2,800 were stomach cancer. And of those, 1,000 were female. And of those 1,000 females, 230 survived. And I am one of them. Thank you. So my name is Lina Miranda, and it is my pleasure to be here 17 years later to talk about that story. So the next picture I would have showed you would have been a picture of me when I was 19, and I had this plump face, and it was that was my first recollection of when did the symptoms start, because I try to think back, like, when did this happen? And it was probably first year university. I was at U of T studying sciences, living in dorm and stressed out, and I started to have heartburn. And the heartburn became a little bit more severe, so I went to my family physician, and he said, you're 19, you're stressed out, it's anxiety, don't worry about it. So I thought, okay, it's a very plausible explanation, so I went off with my merry life, and first year came and went, and second year came, and that heartburn became a little bit less episodic and more of a daily occurrence. So I went back to my family physician. He said, okay, well, we'll test you for H. pylori, and I did test positive, and I was treated for H. pylori. But the symptoms just got worse. And into my third year of university, my symptoms turned into, I was a frequent flyer in the emergency room, and it was, the best way to explain it was like a bomb was going off in my stomach, and it was a severe, severe heartburn. I had no weight loss, no fatigue, nothing was going on except for this crazy heartburn, and I would just drink copious amounts of milk to have the heartburn go away. So I'd go into Emerge, they would look at me my age, and nothing would happen. I would get Demerol morphine and be sent home 12 hours later. And this kept going on a few times, and I went to Dr. Google, and 17 years ago, what can I do? And I thought, oh, I can get a scope. So I went to my family doctor, and I said, can I get a scope? And he kind of chuckled and said, you're 21, your wait list will probably be about a year. And I said, that's fine, put me on the wait list, I've got plenty of time. Anyway, at the same time, I was planning a trip to go to Europe and backpack with a girlfriend of mine. And probably about a month before we were supposed to leave, I was back in Emerge. And I wish I knew this physician's name because he really did save my life. And he looked at my case and he said, why are you here again? You're here constantly for heartburn and severe pain. You probably have a perforated ulcer. And he said, because of your age, there's long wait times for scope, so I'm gonna admit you as an inpatient and you'll be seen tomorrow. And I said, awesome, I can still go on my trip. So the next day, the gastroenterologist came to my bedside and he said, do you drink a lot of pop or do you pop a lot of Advil? And I said no to either of those. And I could see it in his eyes. He's like, there's nothing wrong with you, but you're an inpatient. I have to do this scope. So I was waitressing at the time anyway. I get released, and a week later, I was living with my parents, and my dad kept saying, this doctor keeps calling for you, but he's not leaving a message. And I was like, yeah, whatever. One day, he finally got a hold of me, and a couple of things came to mind. I thought, why is a doctor calling me? Because usually it's a secretary or a nurse. And the first words out of his mouth were, Lina, are you sitting down? And that's not good news. So I sat down and he said, we found a very large tumor and it is malignant, and at this point we don't know the extent of it. So within 2 weeks I had all these tests and I was scheduled for surgery. So 2 weeks later, my next picture I would have shown you is me lying in a hospital bed. When I met my surgeon, and he's a wonderful man, he said to me, so there's a few things that will happen after surgery. He said, number one, we'll go in laparoscopically first to see if it is an actual operable situation. So if you don't wake up with a scar, it's not good news, Lina. Two, you wake up with a scar, it's good news. So had my surgery, sorry, and I remember waking up, and it's a vivid memory. I was looking for the scar and I found one, and it was a very exciting day. So just when you think your life is turned upside down and it can't get any worse, right? You're already fighting stomach cancer. Oh, is it there? Oh, awesome. There's not too many, that's okay.
It was there already, so that's okay.
Perfect. Came the staging. So I guess 17 years ago, things were done a bit differently because I was rushed into surgery. Surgery was done. Oh, yeah, I'll take you. Sorry. There we go. Okay, so yeah, we've seen this. Okay, Twin Towers. There's my stats. That was my plump version of me at 19. And that was after surgery. So then comes the staging, which is never the fun part. And he sat there on my bed and he held my hand, and this was the news that I got. So I went from being what I thought was a healthy, just had heartburn, 21-year-old to I might not survive the next 5 years of my life. And it was really scary. Let me just go up a bit. So I don't want to belabor what going through treatment was and all of that, but essentially back then it was 6 months of 5-FU, yes, that was it. It was 6 months of that and a month round of radiation, which was probably the worst thing I had to go through was the radiation. And after 6 months, I was just left to my regular scopes and CAT scans and hope for the best. Cancer sucks, and everyone in this room, whether you're a caregiver, a patient, or in the medical field, it sucks, and having to deal with it is horrible, emotionally and also mentally. But for me, the worst part about it, and maybe it was my age at the time, was the physical aspect of it. So I don't know if you can tell my height from here, but I'm relatively tall. I'm 5'8", and I should, or at the time, being a healthy weight of 130, I went down to 85 pounds, which that's a picture of me trying to look good. That was probably months after all of my treatment was done, and I weighed about 85 pounds, and I looked like death walking down the street, and people would stare all the time, and it was horrible. And walking upstairs sometimes felt like the biggest win of my life because you have no energy and you're fatigued, and every day is a fight just to even get dressed. So having gone through all of this, I sort of had this eureka moment, and I thought, I never, ever want to feel as weak, as fatigued as I do moving forward. But before I get there, I just want to say, a lot of people still ask me, how did you get through it? It's a crazy diagnosis. And I have so many answers to that, and everything from reading books about miracles to I would meditate and envision Pac-Mans eating away at my row cancer cells, to change of diet, to seeking alternative medicines as well. But there was 3 things that in my mind I kept fighting for at the time, and that was to graduate university, to get married, and then to be a mom. So those were 3 things that I kept fighting for. Anyway, so sort of fast forward a bit. So when I looked that sick and ill, I decided I was going to join a gym because that's what you do when you look that bad. And I remember being very self-conscious about it, but I walked into a gym and I did my first body pump class, and I stood at the back and I barely lifted a bar. But I walked away from that class feeling the most alive I had felt in the past year. And whether it was the endorphins or the music or, I don't know, the fact that I was standing in a gym, I felt amazing. And I thought, okay, I have found something here, I gotta keep going. So when I was stronger, probably a couple years later, there was a mention of Gilda's club here today. I joined Gilda's Dragons. It's an all-female cancer survivor boat team. And we are a motley crew of females. I was the youngest in my early 20s, and there was a lady in her mid-70s, from single survivors to double survivors, and we had a triple survivor on that boat. But when we paddled in unison, and we paddled for life, and it was wonderful. And then I kicked it up a notch, and I joined a military-style boot camp, and I woke up at 4:45 in the morning for 2 years of my life to roll around in the dirt with a rebar. But I didn't care because I was alive, and I was like, I'm gonna keep going. And then I surfed and I ran and anything I could do. I wanted to share my first 10K experience. So for me, I never exercised a day in my life until after what I call post-cancer Lina. And when I crossed the finish line, I just melted. I burst out in tears, and I think the volunteers thought, what the heck is wrong with her? And it was so emotional. So that crossing of the finish line for me, and it was probably about 4 years after, was, I'm winning. I'm actually surviving. I'm a year away from being cancer-free, so to say. And it was a very emotional finish line, but it felt awesome. And so I kept going for this feeling. I often refer to myself as pre- and post-cancer Lina. So even though pre-cancer Lina was very young at the age of 21, post-cancer Lina, I'm still young, I'm only 38. But I have an outlook on life that I think a lot of people who go through cancer have. And we don't wish cancer on anybody, but it does change us. And we do appreciate life every day. And there's not a day that goes by that I'm not thankful for being alive and for the second chance. So when I spoke with Teresa, I said, well, what do you want me to share today? And she said, share just hope, provide some hope. And I thought the best way I could do that is to share with you what life looks like now for me. So 17 years post-stage 3B stomach cancer. So the top picture, so that's my husband and my daughter. So with cancer comes a lot of ups and downs, and bowel obstructions and surgeries to cure that, and a lot of things in between, and fertility issues, but we have our miracle baby. Myself in the middle, I now teach that very same class that I went to, and every time I teach it, I always think back to, wow, I'm lucky to be here, but it means a lot to teach that class. Last year, in 2016, I was asked by Reebok Canada to become an ambassador and share my story of strength, so I now partner with them. I'm an avid CrossFitter, and I'm also working on publishing my book, DNA Moments, where not only I share cancer as part of it, but also just life in general and moments that we go through. So post-cancer can look very good, and I'm a fortunate one that I can share that with you. That's a really bad tattoo, but it does exist on my body. It's 17 years old, so it's kind of stretched through pregnancy and all of that. Fortitudo, fetus, and spiro. Those are Latin words for strength, faith, and hope. And the reason I had those tattooed specifically is because it's sort of my mantra in life and how I want to live every day. So as I close today and we close out the conference, there's one thing that I want everyone to take away, a message, and that's, while we can't change what happens to us, we absolutely can change the way that we look at things. Be hopeful for your future. Have faith that you can and you will succeed. but most importantly, always find that inner strength to keep trying and to keep moving forward. So Fides, Spiro, and Fortitudo. Thank you.
Wow, what a story. I don't think there's a dry eye in the audience. Am I right? Yeah, I mean, it's strength like Lina's that I think drives Teresa and I to do what we do here today. Stories like this inspire hope from something that seems so dismal, a diagnosis of stage 3B stomach cancer, to 17 years later being in the audience right here with her caregiver and her daughter. Can we just give her another round of applause, please? And with that, we'd like to announce that this is going to be the second panel and the conclusion of our evening. So if we can get all the panelists to come down, please.
Wait a minute. Ramandeep. Don't think you're getting out of it either.
So we'd like to start off by asking the audience, do you have any questions for our panel? I bet you anything, there's going to be a lot of questions for this one. All right, volunteers, if you can please grab the mics.
Hello, I just have a question about, I have CDH1 and I had the prophylactic total gastrectomy open about 3.5 years ago, but I've heard now that laparoscopic might also be okay to open for us. I'm just curious what you guys think about that, or what you'd recommend.
So I think, so if you look at how people do after the surgery, the main differences are in the immediate post-operative period. So, you know, a couple of days quicker leaving hospital and maybe a couple weeks earlier return to normal activity. But we know, you know, a year or two after surgery, the problems are the same and the benefits are the same. So what I think is the most important thing is to find a good surgeon, one who understands your disease. And for CDH1, that's, you know, is especially important. And I do both, and I mean, I'm comfortable doing both, but I think the most important thing is getting good surgical care. And the laparoscopic versus open part, even though the differences seem big at the outset, 1 year after surgery, there's really no difference. And so I think, I don't know if Dr. Coburn has an opinion on it, but I do think both are completely valid options.
I agree. I think a laparoscopic approach for CDH1 carriers is a good consideration. A laparoscopic approach for an early gastric cancer, the data's not out yet, but it's probably going to be equivalent in terms of cancer survival. Advanced gastric cancer, it's going to take a few more years for those trials to come out. In the end, colon cancer is approached laparoscopically and open for more advanced cases, and so probably it will be the same. But I think for the advanced cases, there are more considerations for margins. If there's involvement of the pancreas or something else, there's considerations for the cancer and manipulating the stomach and the abdomen. And there's certain cases that we're always going to have to do open. For the early gastric cancers, laparoscopic's a great option. For the carriers and for prophylactic, it's a good option. But a laparoscopic total gastrectomy is a very big case, and you want to make sure you're having the surgery done by someone who does a lot of it. And in a place where if there are problems, I think one of the speakers this morning had mentioned some issues, that they can take care of you, that there's an ICU, that there are interventional radiologists that There's an interventional radiologist at 2 a.m. in case you need someone like that. So you want to make sure you have the surgery done in a place that can support a big surgery like this.
Great, thank you very much.
Any other questions? Go ahead.
Yeah, so I had two questions. The first one is maintaining your iron levels for red blood cells, whatever the iron levels. So how, somebody touched on that briefly in the past, but if somebody can talk about that, especially for a person who's a vegetarian, for example, you know, how, what are the other options? Like there was a suggestion of an intravenous iron supplement. So I want to know. And the second question was, according to Dr. Google, in other countries in the West, there's a lot of discussions and trials already about medical marijuana, especially being given during chemotherapy, which helps people with their food intake. And so I was wondering if Canadian medical community is on the sort of, has something going there. So yeah, thank you.
So I think the approach to iron probably depends on what the needs are. So let's say it's someone that presents already who has profound anemia, who has no iron stores, and they're starting chemotherapy. Probably optimizing dietary sources of iron, while it's important, may not be able to bring your iron up and your hemoglobin up fast enough. So, you know, in that case, Dr. Bresden had talked about the importance of addressing anemia early and the role of iron infusions. You know, if it's someone who, you know, after a partial or total gastrectomy, you are at higher risk for anemia. If you're not already anemic, I think in that case, definitely looking at optimizing iron intake. In terms of a vegetarian diet, it is a little bit harder. So if we look at dietary iron needs, you almost need to double that in someone who's a vegetarian, because the iron is not as well absorbed from plant sources as it is from animal sources. So I think it's definitely something that should be monitored, and maybe is not monitored as frequently as it should be, and then addressed early if you do need an oral supplement. In terms of, I guess I can speak to the medical marijuana as well. So there's been a lot of interest in medical marijuana for appetite, and part of that was kind of based on early anecdotal evidence that you know, people who used marijuana illicitly had an increased appetite, or the munchies. So that kind of sparked a lot of interest in use of medical marijuana for stimulating the appetite. Some considerations. So the evidence for medical marijuana seems to be more supportive of managing nausea, so refractory nausea or nausea that's not responding to management with medication. There's less evidence to support a role in stimulating appetite or as a treatment for cancer-related anorexia. Not to say that it's not used. It could be a side effect, a beneficial side effect, but so far the evidence doesn't support kind of routine use as an appetite stimulant.
There was another question in the audience. Oh, there's many more questions in the audience. Great.
I actually have two questions. My first question is, I'm a Lynch patient, and although I'm not happy about that, I'm grateful for the fact that, you know, I get to do a lot of pre-screening. But my question with respect to the screening is around pancreatic cancer. So I know that there isn't much that can be done to screen for that. I was just wondering, are we making any advancements in that area?
Yeah, I wish Melissa was here to answer that question, because she's leading a lot of that with Steve Gallinger. Screening for pancreas cancer is very difficult, and they've done a lot of work looking at screening for patients who have very strong familial profiles for pancreas cancer.
And a lot of the trials have come up negative, so they haven't been very helpful. Hopefully at some point there will be some options, but right now there's not really good options for screening for pancreas.
Thanks. Second question is, do we know why there's such a high rate of gastric cancer in like places like Japan and South Korea? And the reason I ask that question, is there anything there that can help us here as our numbers grow?
It's a bit complicated. So the most pertinent cause and the reason why it's so much higher there is their H. pylori rate is much higher there. So H. pylori is an infection that basically all of humanity used to have, and in Ontario the rate is about 20% now, and we believe about 1 to 3% of people with H. pylori will eventually get gastric cancer if it's left alone. And in 70 and 80-year-old Japanese men and Korean men and women, the rate is much higher, 80 to 90%. So they had much, much more H. pylori back then, and it's not just East Asian countries, but Eastern European countries that also have a lot of stomach cancer. We do think diet plays a role, so pickled foods, processed meats, maybe smoked meats may play a role, and there's obviously some genetic part of it as well. So cleaning our water, using refrigeration, avoiding processed meats, excessive processed meats, avoiding excessively salted foods are some of the things that we can learn from the Japanese and the South Koreans about, reducing the risk of stomach cancer. But we know that some of it's just from chance alone. 99% of people with H. pylori don't get stomach cancer, and why do that 1% or 3% do? We're starting to understand why, that there's not just the bacteria, but our environment and ourselves, our own genetics that play a role in that. We do know there is a bit of clustering in families. So if you have about 10% of all stomach cancers seem to have some sort of family link, though actual genetic disorders are rare. And there's places where there's a lot of stomach cancer. They say about half of all the stomach cancers in the world are being diagnosed in China, and they're much more behind than South Korea and Japan in terms of screening and treatment. And the South Koreans and Japanese do so much better than us, stage for stage, in terms of treatment and outcome, but it appears that the Chinese don't. So there's probably how healthy people are, how much they smoke, how early the stomach cancer is found, what support there is for stomach cancer treatment. So it's a pretty complex problem. But H. pylori, if you had to, I'm a very long-winded person, especially when I'm tired. So H. pylori is the answer.
Thank you very much.
There's a question down.
Hi there. I really wasn't sure what I wanted to ask coming here from a perspective of someone that's new to this and learning a lot. I stayed the whole day and wanted to involve myself, but I'm curious, as terms of survivors or caregivers or anyone that's been supportive of people who have gone through this journey, how would you recommend or share your experiences of how people in your life were supportive and helped you get through it, in terms of how someone like me, if I ever experienced someone that did have it, or any type of cancer in this matter, how I could be a rock for that person and be a good support system. Do you guys have any advice on that?
You want to go first? Sure. Wow. It's hard to say because I was so young and some of those friends aren't around anymore. My family is, though. I think for me, my family was just shocked, and they didn't know how to go through it. And for me as a patient, I didn't want people crying around me all the time, and my mother and father just cried all the time and went to church, and everybody was praying for me, and I was like, I'm not dead yet. So that really, I think it's really hard too, because every patient's going to be different, right? And some people are more open and speaking about it and want to talk about it, so maybe in those patients you want to help them and listen, and then there might be others that just want to ignore that it's happening and so talk about something else. And I think it's knowing the person that you're with and honoring how they want to handle it. I have a little funny story. I didn't put it into my presentation, but my husband just reminded me of it. Anyway, so when we met about 1.5 years after I was diagnosed, and anyway, so I thought, well, I should probably tell him my survival rate. So I sat him down and I said, okay, I really things are getting serious, but you have to know that My survival rate is, 25% chance, 5 years. And we stuck through that for many years, and I even forgot I told him this. And I was doing research for this and looking up what was my stage again and what was my prevalence. And he's like, "You liar." And I was like, "I did lie, didn't I?" I was like, "I didn't want to scare you away." So I think I was the kind of patient who was maybe a little bit more optimistic of things. And I was just like, yeah, don't worry, I'm gonna get through this, right? And so that was me as a patient. And I like talking about it. I still like talking about it. I'm very open. So I think it's respecting that person and how they like to deal with things.
Yeah. Thank you. I wouldn't disagree. Every individual is different. And every stage that they're going through, be it an early advanced stage of diagnosis or advanced or metastasis, that also decides how or what kind of support you give. I think we were fortunate. We had family and friends who flew in from all over the world, all the way from India, from the US, from California, who came in and provided support, who were there. And so it's a combination of being a strength and a rock. It's a combination of being a shoulder to let them cry, knowing when to let them be. In my case, she wanted to eat spicy food, which was her enemy, but she still wanted to do it. And sometimes giving in and letting them do and maybe letting her throw up is a better choice than, letting them agonize, because the argument is, if I don't have time, I might as well do what I want to do. And so it's a combination of things. It's a combination of giving them the security that if they're not there, the children are going to be looked after. A combination of, you want to talk about these things. What would you want the kids to be? What would you want as a legacy once you're not there? And I think these are very hard discussions to have, but I think being open as a caregiver, reading, talking to people, seeking counsel yourself on how you can deal with it is going to be an important piece of it, because you don't have all the answers. So I think that's all I can say, that I think today, compared to 17 years back, I think we're much more advanced. Technology is much more our friend in being able to communicate, being able to reach out to people than it was in the past. And I said, that's my message, that reach out, talk, and use that as a way of dealing with the situation on hand. Thank you.
Hi, I have a question as it relates to food and supplementing. So I think you showed a really great picture where the plate is full and it's half vegetables, a bit of protein and a bit of carbohydrates. But then the reality is that the actual amount that people are eating is substantially smaller, especially after they've had their whole stomach removed. So knowing that they're getting less absolute calories in, what would you say is the role of supplementation, knowing that they also can't absorb nutrients the same way through like B12 or iron specifically?
So there are certain nutrients that are of a concern if you've had part or all of your stomach removed. So the best thing is to still try to optimize as much as you can. It could be putting more of a focus on making sure that you include those foods that are rich in iron, that are rich in B12, that are rich in calcium in your diet, and kind of prioritize those foods. But also to know or to work with a dietitian to keep track and say, okay, you're not meeting your needs, and maybe you do need to take a vitamin mineral supplement. So for most people, the research has shown that taking kind of a general vitamin mineral supplements doesn't really offer any benefit in terms of health outcomes. So we say to try and really get your nutrition through food as much as possible, but recognizing there are going to be some challenges. So certainly if you're at risk for a deficiency in a particular vitamin or mineral, definitely we would want to look at supplementing.
I just want to add one thing. I think Denise had a great topic. I think lots of you guys who have gone through this found that maybe it isn't so easy to get nutritional support after surgery. And I think as much as we try to ask our hospitals for increased support, I know at Mount Sinai, even though we do a lot of stomach cancer, it's hard to get outpatient dietitians to see patients, and we're working hard to coordinate that. But if you guys can write letters to hospitals, to your MPs, to say, you go through such a big surgery and you have so much support in hospital, and then you're kind of left to fend for yourself afterwards. I think systematic change is needed to support patients with stomach cancer. It's a rare cancer. It's been a quiet cancer till these guys started this group and other groups, and so I think there really needs to be a rallying cry for support longitudinally. Like, we know it's a year and a half of a struggle just to get to a new baseline, and you guys deserve support during that time. It shouldn't come out of pocket. So I think if this could be a burning platform, you guys should go for advocating. We'll advocate on your behalf as well, but it's much more powerful hearing the patient's stories and the caregiver stories. So if I can ask one thing of you guys, that would be it.
Any other questions from the audience? All right. Are there also questions online? Okay. Passing the mic.
Actually, I know someone touched upon it earlier on medicinal marijuana. And for me personally, like, it's helped me a lot in my recovery, especially with keeping food down. It would get stuck in my esophagus, and it would help alleviate that, actually. And it would increase appetite. So I definitely think it played a role early on in my recovery. So I just wanted to add a little bit of that, and hopefully whatever tax money they get from that, they can put it back into research, which would be great. But my question was, it seems like there's a lot of discrepancy in terms of care, not within just Ontario, but within the province. I'm not too sure how the intricacies work within the health system. But on the federal level, is there anything that's being looked at to kind of standardize not just stomach cancer, but cancer in general, in terms of care or where the money goes to? Because it seems like the numbers are all over the board.
And there certainly are things that are being looked at provincially and federally. There's organizations like CPAC, which are looking at tremendous amounts of health data across the provinces. And you would think that it would be easier to look at outcomes across the provinces for patients. It's very difficult. It's very difficult data to work with. The data comes in at different points in time, and there are groups like CPAC that are working to try to get that more homogeneous. If you look across the provinces, all the reports will say all provinces except for Quebec, because they report their data quite differently through CIHI than the rest of the provinces. Even within Ontario, you would think for cancer it would be easy to know what the stage is of everyone within the province, but we don't know that. We know that for breast cancer and colon cancer and lung cancer, because those are the common cancers, but when you fall off past that in terms of the number of incidence cancers, they don't know the stage. And that's why we had to go out and look at the charts in each individual hospital, was to get the stage. And that is a crucial point in knowing how well you're doing in terms of outcomes. So I think the data structure is just getting to a point now that you can use it and you can have reliable examinations of data between the provinces, and then within the province, what's happening here versus outside of the GTA versus London versus Ottawa. How are we caring for our patients differently? And can we learn things from the group in Ottawa? Can the group in Kingston learn things from the group in London? And that's one of the things we're working with the course. To get all the surgeons together across the province and say, okay, here's how we do it at Sunnybrook. How do you do it at Mount Sinai? How much support do you have from your dietitian? Because, at our hospital, we're having this problem. Well, I don't have a problem with dietitians. We have a problem getting psychiatric support. Can we get that more evenly spread across the province so that everyone has the support that they need?
Go ahead, Dr. Bresden.
Great, thank you. So, as you mentioned, Natalie, so cancer care Ontario, within Ontario, there are all these metrics that are being captured, which is very important. A big push is for psychosocial oncology to move into the clinic. So it took us 2 years, Kien, to get you into clinic, but it comes from us, right? A lot of it too. I mean, it comes from the physicians to actually continue to push to ensure that our patients are properly cared for as well. So, it's working together in this multidisciplinary team, but to ensure that, we have psychiatry in the clinic. So that's the latest buzz is psycho-onc. So psychiatry is in our clinic, because as you said, Natalie, it would take probably 3 to 5 months for patients to be seen by psychiatry, and they're in acute crisis at diagnosis or within treatment. With our dietitian, we've been very fortunate at St. Mike's. Denise sees all of our new patients in clinic, but once again, that's a resource that has been threatened sometimes to be taken away. And we have to continue to fight, and we have to advocate for our patients as well as patients advocating for themselves. So I think, though, in oncology and cancer care, there have been huge improvements have been made, and that's because there are these metrics that are being captured. Improving surgical outcomes, improving the preoperative care of patients, and improving their journey through the entire within their entire treatment.
Any other questions from the audience? Okay.
I'd just like to ask, what is the rate of recurrence of stomach cancer, and is it directly related to the stage of the cancer?
Yeah, so it's related to the stage. It's related to the way the cells look under the microscope. So it's related to whether it's diffuse or intestinal type. It's related to if there's cancer left at the margins. It's probably related to how you take out the lymph nodes. It's certainly related to whether you get chemotherapy or chemoradiation around the time of the surgery. So it's very complex, actually, and there's a lot of things that influence it, and that's why it's so difficult with a rare cancer like this to say that your recurrence rate is what you would expect or not what you would expect, that your survival rate is what you would want or it's below what you would want. If you have a small cancer, it's hard to know, was it more related to biology or was it more related to lack of chemotherapy? So it's something where we're trying to gather data, and eventually we'll get to that point.
And there's still a lot of mysteries. We have changed staging for stomach cancer 3 times in the last 7 years. They're all subtle changes, but we're getting more and more information about it, and so it's a continually evolving field as well.
We have a question from one of our members out west, and this is related to, I guess, the psychosocial aspect of coping with long-term survivorship. So for a lot of patients, they, after 5 years, they're considered cured, and they no longer get the follow-up. But then something happens, and then they get scanned, or they get some kind of intervention. How would you suggest for these patients to cope with? Hello?
Just scream.
How would you cope with anxiety? Dr. Dang.
Oh, that's so tricky because.
Oh, we're back.
There's a lot of things that can. It's like after 5 years, you're considered cured and you don't get the supports that are available yet. At the same time, actually, there's a recent study that talked about like the prevalence of PTSD that's in people who have been diagnosed and gone through cancer treatment. And for anybody who's been through a major trauma, and actually cancer treatment, cancer diagnosis is trauma in itself, you never forget. Those things don't go away. Whether it be a diagnosis of cancer, whether it be another trauma, things aren't going to go away. And one of the things that can happen in a sort of PTSD type setting is you get triggered with every kind of memory or any kind of re-experiencing. So scanxiety is like when you go for a scan, it's almost like a triggering of the trauma all over again, but also the anxiety of what's going to happen if, what are the results going to be. So I see patients on a regular basis have that week before a scan or a test, have this heightened anxiety. My question is like, what do you do about it? I'm like, I have no clue. No, actually, a couple of things. First of all, one of the things is like, like the more treatment for anxiety disorder in general, basic principles of treatment for anxiety is the more exposure you have, things get a little bit easier. So if you're afraid of heights, for example, the treatment is you start slowly expose yourself to more and more heights, and eventually you learn that being high up is a safe thing. You can't do that with cancer because you're not going to be able to have scans on a regular basis, like every day, just to sort of learn that a scan is going to be safe. So you can't do that. So sometimes, either I have actually recommended to some patients maybe a little bit of a Band-Aid solution for that week before, like a medication that can help with anxiety. The same way that for people who go on a plane, sometimes take a medication just to help for those times that they're on a plane. Very, very brief, very, very simple, very not on a regular basis, because those medications can be addictive. On the flip side, there's the idea of continuing with all the various ongoing psychosocial supports that may still be available. I really am a big fan of mindfulness-based cognitive therapy and mindfulness-based practices. The idea of learning those coping strategies and employing them when you need it, and that anxiety is a time when you actually need those coping skills. And to be able to learn, to be able to use meditative practices, to be aware and more accepting of the current experiences, whether it be anxiety, whether it be fear, whether it be nausea, whatever, during those times. You got to develop those skills on an ongoing basis when it's easy to develop those skills, as opposed to when you really need it. It's like you practice CPR before you have to actually do it in an emergency setting. You do fire drills before you have to in a safe way before you actually practice it in an emergency setting. When you're really anxious, you may not be able to access those kinds of coping skills unless you practice them in a more calm way. So I really am a big fan of mindfulness-based practices.
Thank you. We also had a question online. If you could give it to our online coordinator. While our volunteer makes her way towards our coordinator, there's another question, and I guess this one's mostly for our caregiver speaker on the panel. The question is from somebody who is dealing with losing a spouse, one of our members out west. Essentially, the question is, how do you deal with talking to the children?
I have, I don't know whether I mentioned or not, my boy is 7 and my daughter is 13. And one thing I did throughout their mother's journey is that they were totally part of it. They were there the day she got diagnosed. They were there every time she came out of post-op. They were there the day she was admitted to the hospice. And they were there the morning she passed away. I made sure that they participated in, children are very resilient. So don't for even a moment think that you want to exclude them or you want to keep them out of, save them the misery, because they have a tendency to be able to cope with it better than we understand. And they have simple minds. And they are able to put pieces together and they are able to move on with it. I've taken 6 vacations since March this year with my kids. We are off to Hawaii in December, and they're happy. They are getting A+ grades. The teachers, I meet them regularly, say that nobody would ever know that they had such a big tragedy in their life. We have smiles, we have laughters, we have moments, and we never forget Mom for a minute. She is always a part of everything we do. We make fun of her in absentia, and she's not there to defend herself, so that's great. But I only suggest talk to them. There is no other way. Make them understand that we did everything possible to try and do what we could for Mom or Dad, and we have done everything possible to make sure that you guys are going to be safe. They ask me a question about what if something happens to me and they're going to be orphans. You don't walk away from those questions. You answer them. I have done things which I didn't. I have a will today, which I never did in the past. I have given them the comfort and security of the fact that they know who would take care of them if I was not there. So we have spoken about eventualities. And there is no fixed formula for any of this. I think everybody has to deal it with their own way, but the only thing I could recommend is do not think the kids cannot deal with it. They might go through dips and turns and downs, and if you don't think you can handle it, get them external help. My children spoke to counselors, but they did not need additional help. But even today, my son, who's 7, tells me that if he feels low, he talks about mom to his teacher. And I think that's the point you want to get to. Yeah? Thank you.
Thank you so much. And Matthew, our online coordinator.
Maria from Toronto wanted to know that she heard on the news that proton pump inhibitors have been linked to stomach cancer. What is the medical opinion? Is it true?
You take it.
Dr. Coburn is the evidence expert, but it's one recent study. It was from Hong Kong, and they looked at patients who were on proton pump inhibitor for a very long time. It's a very small study, and the news headline is that it's 8 times higher rate of cancer, which I mean, I'm not a math expert, but seems excessive. It is not what we would call very good evidence. I mean, maybe there might be a link there, but I think it's too early to tell. And every once in a while, there's a small study that shows something that a bigger study doesn't support. We know there might be a link there, but I would be cautious in terms of putting weight in one study from another place in another center where things might be very different. So.
Yeah, it's an interesting study. I think as we've talked about gastric cancer and esophageal cancer, there have been huge swings in incidence over the past several decades. If you look in the 19-teens and the 1920s, gastric cancer was the most common cancer in North America. And so who would have guessed that it's the 10th most common cancer in Canada right now? We do know that tumors of the GE junction, or tumors between the esophagus and the stomach, are rising. And no one really understands why that is. Many people think it's because of obesity and because of reflux. But during that time frame, we've also had an increase in all of these acid blockers. So it's a very complex interaction. If the increase is because of reflux, the people who have reflux are going to be the ones who take the acid blockers. So it's very difficult to sort it out, and it's a very small number of cases. I think it's something that needs to be looked into more, but very early to throw the baby out with the bathwater.
Before we conclude, we'd like to open it up to the audience one more time, if anyone has any additional questions. All right, so we'd like to give a big thank you to our panel members and all the speakers today. So if we can give a big round of applause.
So both Katy and I are actually incredibly humbled that everyone is here today and everyone took time out of their schedules. People flew, people drove to come and hopefully learn something, hopefully meet people that they could talk to, and most of all, meet people that have gone through or are going through exactly what you're going through. That's why we started MyGutFeeling. We started it because we want to help. We started it because we are very lucky, and we say it every day, we were early stage cancer diagnosis. And so our way of giving back is to try and help people. And so we're incredibly humbled. I also wanted to say a very huge thank you to our title sponsor, Lilly Oncology. We've had a great relationship with them, and we really absolutely could not have done this without them. And I will pass it over to Katy if she wants, and to St. Michael's as well.
Yes, a big thank you to St. Michael's Hospital. We run our, yeah. As many of you guys know, we run support groups on a monthly basis, with the exception of some holidays. Teresa and I, we kind of run MyGutFeeling off the side of our lives. We don't get paid for what we do. It's purely something in a way to give back. As Teresa's mentioned, we were extremely, extremely lucky. And to be able to pull this off, this conference, to have the support of this wonderful, wonderful panel, the survivors, the patients, the caregivers, the medical experts, you know, we're only a year and a half out, and, you know, just watch and give us a couple of years, and just stomach cancer will be way, way, way up there on the map. So we just wanted to say thank you to everyone, including the audience, for participating, and we hope to see you guys in our upcoming support group.
So we do have, there's still some refreshments and coffee out there. We encourage you, if you can, to stick around and talk to people and continue that support. And we also wanted to remind you about this Thursday, November 30th. Take pictures. We have buttons. You can get them out front. Remember the lightings across the country. Post on social media. We have some awareness products out there if you'd like to purchase them. It's all about being able to do more programs. So if you can help spread the word, I think that for us would be a great way of helping us. Help spread the word. We can't do it without more support and more donations and all of that. And just last but not least, we wanted to wish all of you incredible health, incredible love, happy holidays, and next year we will see you on November 30th for our next, hopefully our big conference and our big gala to celebrate it. Thank you. Oh, and a huge, huge thank you to our volunteers. My goodness. Thank you to our volunteers who have been here last night and all day today. And to our technicians who have made this such an amazing, amazing presentation for us. We really, really do thank everybody. Thank you.